This conference will now be recorded.
All right. I think we're just about ready to start. So I'd like to start by saying good morning, everyone. Thank you for joining us today on our virtual academic day entitled A Review of COVID-19. My name is Dr. Anzofar, whomever does not know me here. I'm the Emergency Medicine Chief Resident with the Zayed Military Hospital program in Abu Dhabi. As most of you know, we're living through a crisis with a ever-changing phase, and at times it does feel like we're overwhelmed by how unpredictably devastating this novel coronavirus can be. The physicians all around the world are struggling to equip themselves with the best tools and mindset to fight this unimaginable pandemic. However, in the midst of all this chaos, we have hope. Every day, more and more information is released that sheds light on the mysteries that surround COVID-19. Today's objective is to compile and analyze what we know so far and essentially dissect it into digestible, somewhat absorbable bites of wisdom that we can all use to level up our understanding of this disease. Dr. Saleh Fares, our program director, he would like to extend his regards to everyone here. Unfortunately, he may not be able to join us today as he's tending to some urgent matters at the hospital. So before we start, I would like to remind all of you guys to turn your microphones off to allow the lecturers to speak without any audio interference. You will have the opportunity to ask questions at the end of lectures whenever it's feasible. Also, all lectures will be recorded and made available to you approximately 48 hours after the program has ended. The instructions for this will be made available on the on-screen chat window. Also, please note that none of our lecturers will be disclosing any personal information for any patients during their talks, and I would advise you similarly refrain from sharing any confidential data. So with that being said, I would like to introduce our first speaker, Dr. Omar Ghazanfar, who will be talking about the approach to the suspected COVID-19 patient. Dr. Omar completed his MBBS at the age of 25 years old at Karachi University, and he subsequently spent about 13 years in the UK at various different hospitals. He was initially in trauma surgery, and subsequently he went into emergency medicine before he moved here to the UAE. He has completed a master's in disaster medicine, and he also has a fellowship from the Oxford Deanery in appraisals and performance management. He also holds a leadership certificate from the NHS Leadership Academy, and he has worked for NHS England as an advisor. Currently, he is our co-chair of trauma at Zayed Military Hospital, Abu Dhabi. He's the editor of Emirates Society of Emergency Medicine newsletter, and also he's an editor with the Saudi Journal of Emergency Medicine. For those of you who do not know him, he has presented widely in a lot of different international conferences, alhamdulillah, and he served as a faculty member in various forums. He's also the member of the IFEM NATSIC committee, which looks at the use of technology in medicine. And I think without further ado, I'll hand over the controls and the stage to Dr. Omar. Welcome, Dr. Omar.
Welcome all. Assalamu alaikum, and thank you for all the kind words. I hope it will be an enjoyable day. A lot of what is anecdotal. So a lot of it is based on data coming from various parts of the world. Some of it is published in various journals as case reports and reviews, including things like in the Lancet, in the BMJ, and the New England Journal of Medicine. So obviously we can't cover the whole spectrum of disease in the novel coronavirus spectrum, so I'll try and be as brief as I can. I'll talk a bit about workflows which have been going through with NHS England and the Royal College of Emergency Medicine, and I have to take questions either after the talk or after my email would be there, so I'm happy to discuss via email as well. Great. So we're going to talk about what is SARS-CoV-2, how to approach patients, what are the main signs and symptoms, and so on. So essentially, it is a pandemic. It is caused by the novel coronavirus. The outbreak was identified in Wuhan, China, in December 2019. And was declared a public health emergency of international concern on the 30th of January earlier this year. And as of the 11th of March, it has been declared a wide pandemic by the WHO. As of today, there are nearly 2 million cases of COVID-19 in approximately 210 countries. The death total is around more than 126,000, and approximately 500,000 people have recovered. The case fatality rate varies. It's approximately 4% in China, but varies significantly, especially in some of the European countries, Italy and the United Kingdom, where it's more than 10%. So the key points which I'd like to talk about today would be, I'm going to touch on some of these quite briefly. So we'll talk about triage, we'll talk about screening patients, we'll talk about how work should flow through the emergency department and through the hospital. We'll establish how to be suspicious of COVID-19, some of the signs and symptoms, how the disease progresses, when to escalate and where to dispose, and some of the risk factors which sort of point towards a high morbidity and mortality rate. So essentially at triage, these are all symptoms and signs which have been, a lot of it is through anecdotal data. Some of it has been published. Some of it has been sort of gathered through Delphi, so senior consensus, etc. But this is what we have for the moment. So any patient presents to the emergency department with influenza-like symptoms. Now, self-reported or documented fever, so it doesn't have to be documented fever, and the patient could be saying that I had subjective fever. Any signs of upper respiratory tract infections, cough, sore throat, dyspnea, or any additional respiratory symptoms, myalgia or fatigue. Now, there are caveats to that as well, because not all patients present with influenza-like symptoms, and we'll talk about that a little bit later on in the presentation. Travel history, is that relevant? Probably not so much so. It was probably relevant in the beginning when it all started. It may be relevant for regions without local transmission, but as of now, most nations and territories have local transmission, so it's probably not relevant. Contact history with somebody who was positive for COVID-19, travel history to a region with a history of local transmission, close contact with a confirmed or probable case of COVID-19 within 14 to 28 days. This number is arbitrary. Some places it's just 14, some places between 14 to 28. So it can be quite variable. Fever of unknown origin. And we talk about that, and I can give some personal thoughts about that as well later on. So fever with an unidentified source of infection is also a risk in terms of raises suspicion. So close contact with a person with acute respiratory illness who's traveled within 14 to 28 days. The last one's a bit new because this is something which I just read recently from the CDC. So laboratory exposure to biological materials, so primary clinical specimens, viral cultural isolates which have known to contain COVID-19. So this would be very relevant for hospital staff working in the lab. Now, the thing to take home is that if the patient has a COVID negative screen but does have influenza-like symptoms, they should be considered COVID positive for the purposes of triage screening and cohorting. So what this essentially means is that if a patient, for example, comes on 2 weeks ago, he's tested, he's negative, he represents 10 days later and he still got influenza-like symptoms, it doesn't mean if the initial swab's negative that he can't be positive. So it can be positive within any time, or he could become reinfected, or he could be initially not exposed. So there's lots of caveats to that as well. How does your workflow depend? It obviously depends on the type, design of your emergency department, the availability of resources, manpower, logistics, nurses, PPE. There are a couple of designs suggested by the Royal College of Emergency Medicine in their Clinical Leaders Forum, which I'm part of. So I will try and share. I will share some of those with you. So essentially, in terms of this is one of the flow charts which came through the Royal College Consensus Forum. I'm not going to go through each aspect of it, but essentially, as Anzal said, we will share this later on, so you can have a look through it. Triage should be at front door. It's a binary triage, which sort of tries at best to separate patients from with respiratory illness to non-respiratory illness, assesses the level of severity, which then guides treatment, investigations, and disposition. So this is something which was come up in the NHS England Public Health Forum, and this will be shared with you, so you can have a look through it. It doesn't work for all services, it doesn't work for all departments, but it's just a guideline of what you can follow. This is another one. This came out of the same forum. This is something which is done at the Homerton University Hospital in London. Again, it's front door triage met by the senior nurse or senior physician. It has PPE guidance. It gives you, patients who are at high risk, pregnant patients on chemotherapy and so on. Focused assessment, not detailed history, and then, essentially a front door triage. A front door triage can essentially tell you whether the patient is low risk or high risk, and whether the patient can be discharged or whether the patient can be or doesn't need to be seen by in your majors or your resus. It's a big chart, it's a big flow, so I'm not going to go through each and every aspect of it. It is something which needs to be decided and done in conjunction with your own service guidelines, your own clinical practice guidelines. It is just a it essentially gives you a guide of what you can follow, who you can discharge, who needs to be seen in resus, who needs to be seen in majors, who needs isolation, and so on. Obviously, you got to take it into account that most hospitals and most emergency departments, unless they're really well built, wouldn't have negative pressure rooms or not enough negative pressure rooms anyway. So disposition has to be looked at quite carefully as to where these patients will go, whether it will be into the ward, whether it be into the community, if into the community, who follows them, etc. So as part of our day today, there'll be some talks which I've just briefly mentioned, PPEs, presence or absence of isolation rooms, who does surveillance. So these are all very important, pertinent points, and they will be discussed during the course of the day. So I will not go into too much detail about them. So how do you approach a patient with SARS-CoV-2? So basically, you like any other patient, full PPEs as required. PPE guidance should be as per your local Department of Health, MOH, HAD, whichever part of the world you are, their policy as to see which patients. My personal approach is, for the moment, is COVID positive till proven negative. We've had a couple of patients who have been positive, who have presented with atypical symptoms. So just consider everybody positive until they are proven negative. ABCD approach. There are many approaches now in terms of CPR and so on, with different guidance from both the Research Council of the UK as well as the AHA. So follow guidance which is being implemented in your workplace, in your hospital. Try and avoid any aerosol generating procedures, and treatment is supportive. Now we'll talk a bit more about the aerosol generating procedures in subsequent talks when they talk about PPEs and what type of procedures are classified AGP. I mean, even simple things like nebulizers make me a bit edgy now. So unless patients have severe asthma or so on, I've actually started giving patients inhalers through spacers now, as compared to nebulizing them. So how do you establish a suspicion of disease? So presentation, as I mentioned initially, is extremely varied. Most common is a non-specific flu-like illness. The majority of patients present with more than one symptom or sign on admission. So they could have fever, they could have cough, they could have shortness of breath, they could have things like arthralgias and myalgias. But bear in mind, the combination of all all three is not good. And generally, if you have the triad of fever, cough, and shortness of breath may not be something which is present in all suspected or positive patients. About 44 to 94% patients present with fever. Varied temperature cutoffs have been published in literature. I've got a list of references which you can go through if you want at the end of the lecture. There's no consensus. There's some data which came out of Washington which recommends any patient with a temperature of more than 38 should be considered suspicious. You've got to take into account patients' immune status. Are they healthy? Do they have any risk factors? Are they on any medication regimens? Things like long-term steroids, immunosuppressants, chemotherapy, or if they've, for example, if they're presented with patient, temperature of 37 and they've told you they've had a couple of paracetamols 2 hours prior to presenting, so that obviously you've got to take that into account. About 68 to 83% of patients have a cough. Between 14 to 16%, 61%, sorry, have sore throat. 11 to 40% have shortness of breath. Fatigability is present in about 23 to 38%. Complete upper respiratory tract symptoms in terms of sore throat, rhinorrhea, nasal or sinus congestion is present in about a quarter of the patients. Arthralgias are present. Headache, simply headache could be a presentation. Confusion, about 9%. So there have been some anecdotal cases in China, in Korea, in the UK where patients present with fits. Patients have present with seizures, which some of the clinicians and researchers are attributing to viral encephalopathy. You can have GI symptoms, nausea, vomiting, diarrhea, about 3 to 17%. I actually had a patient who just presented with abdominal pain and high-grade fever. With no influenza-like symptoms, and he turned out to be positive as well. A couple of reports have come out from ENT consultant specialists in the US and the UK that patients have presented with anosmia, loss of smell, loss of taste. So anything can be anything. So just be suspicious of any patient who presents to you. So this is a brief summary of what I've just talked about. Sort of just remember what you see in severe disease is confusion, it's cyanosis, it's hemoptysis, it can be persistent chest pain, which is consistent with myocarditis. It can be patients presenting with persistently high-grade fever, not resolving with acetaminophen fluids, and decreased white cells, specifically lymphopenia. Some anecdotal reports, I mean, there's 25% of patients who can have co-infection with other viruses. So you could have influenza positive patients who also are COVID-19 positive. Depends on where you are. Although rates of bacterial infection are low, they are possible, and generally they tend to be higher in those patients who seem to be developing nosocomial infections and are ventilated for a prolonged length of time. So we'll talk about the course of disease. So disease progression, so this is also anecdotal data comes out of the US, it's come out of China, and it's come out of South Korea. So fever, so median day, sort of 4 to 12 days in survivors. Dyspnea, the median time is about 13 days. Cough, 19 days, even in survivors. It's still present in 45% of survivors on discharge. So just remember, presence of cough at discharge is not a reason not to discharge. And about 72% of patients who died had cough at the time of death as well. Talk about complications. You can get sepsis. Ranges about 7 to 13 days. and generally about 9 days. ARDS takes about 12 days on a mean. But anecdotally, respiratory status can decompensate very rapidly. It is sort of goes in with the cytokine storm. Generally happens when patients are on vents or just before they go on vents. Duration varies. You can have acute cardiac injury with the range of about 10 to 17 days with a median of 15. Represents viral myocarditis and generally is not a good sign, whereby patients who develop cardiac injuries generally tend to have poor outcomes. Again, acute kidney injury happens about 15 days as a mean from the start of disease. Is again a poor prognostic factor, especially patients on vents. You can have secondary infections, bacterial infections, other viral infections. So the time from when you initiate invasive ventilation to VAPS, so VAPS, ventilated associated pneumonia, can occur sort of 8 days from the start of patients being on vents, mean being 2 to 9 days. So in terms of how the disease progresses, so about 80%, 81% of patients have mild to moderate symptoms, and 81% of these patients generally do not require hospital admission. 14% have severe symptoms, hypoxemia, or more than 50% of involvement of the lung, and 5% are really unwell. So they have multi-organ failure, they're in shock, they're in respiratory failure. Now, speaking to colleagues in the UK who are working in the emergency department and critical care, now obviously the threshold for intubating patients has decreased in the sense that previously patients were being intubated. Sorry, this is all anecdotal, so there's no science behind it as yet. It's all on personal preference and people working in critical care. But essentially, a lot of people are now intubating, tolerating a lower threshold for intubation. So if you have, so they're not intubating people who are, saturating at 92% and otherwise stable. And in some places in the UK and the US, they're waiting till about 88% on high flow before they are thinking of intubating patients. The reason is obviously lack of resources in terms of the availability of ventilated beds and intensive care facilities. Generally, if you're unwell and you require ICU admission, the median time from when you develop the COVID-19 to ICU transfer is about 12 days. There are certain indications for admission to critical care. The most common admission is hypoxemic respiratory failure. So this would be somebody who is on high flow oxygen, 19 liters, and still saturating at 86%, tachypneic, getting tired, So those would be the most highest on the list for patients who end up going to critical care. Now, mechanical ventilation initiated in about 53% of patients who are vented develop ARDS within 72 hours of initiation of a mechanical ventilation. If they not, so not all patients who are intubated are in ARDS at the time of intubation. They may be in hypoxemic respiratory failure. But what's come out is that in most places, about 100% of ventilated patients eventually develop ARDS. Initial presentation with shock is extremely rare. In about 67%, they have vasopressor requirement. In about 33% of patients, there's associated cardiac myopathy, which can eventually lead to cardiogenic shock, which can be late in course. Again, this is anecdotal. There's no gold standards yet established for these patients. Now, in terms of disposition, 53% die purely because of respiratory failure. 7% die because of the myocardial damage. There's mixed circulatory and respiratory damage in about 33%, and 7% have no identified cause. And presumably due to logistics, resources, not all patients get autopsies. So general timeline, so the median timeline, if the progression of disease leads to mortality, it's about the range is between 15 to 22 days, and the median is 18.5 days. They've been noted to have two peaks of mortality, one at 14 days and one at day 22. Time of illness from onset to discharge. So if somebody is going to be discharged off vent, generally it's about 22 days. For mild to moderate patients, the median duration of hospitalization is about 12 days. So who escalates and how do you escalate? So this is a algorithm for escalation plan for adults, which has come out of Guy's and St Thomas's in London. So in terms of, they've classified patients based on triage categories. So they've used something called the Manchester triage, where they are triaging patients from green to red. Green being patients saturating, 94% with a respiratory rate of less than 22. And if patients in emergency department, they can be discharged with advice to self-isolate. If they are saturating just over 94% but have an FiO2 requirement of 28 to 40%, they are admitted to the ward. The amber to red ones are the ones who potentially require critical care. So you've got, saturations less than 94. The FiO2 is 40%. Despite optimization, you start them on rebreathers, 15 liters, and they eventually proceed to, in a peri-arrest purple state. So, I mean, these are just numbers which are part of the Guy's and St Thomas's organization. I'm sure every hospital has their own. The merit team, which is mentioned here, is the intubation team at Guy's and St Thomas's. So they have a specialized intubation team which does all COVID intubations. So not everybody is intubating. And as per all the guidelines, the senior most person intubates anyway. This is again a tool which was updated on the 20th of March, looking at admission criteria to the floor in hospital. This came out of NHS England. So they've got 5 criteria: so fever, cough, dyspnea, traveling from at-risk areas, and contact with a confirmed COVID-19 patient. So if OBS are okay and patient has only one criteria, they can be discharged home. This is according to Public Health England. If they have 2 or more, then they go to a COVID area. Looking at presentations, and obviously there's a range of presentations from 1 to 5 with fever, no hypoxia, chest X-ray negative, discharge home. Patient number 2, temperature with consolidation, hypoxic, can deteriorate, admit, isolate. And then from 3 and above, they all end up eventually having a requirement for critical care. Initially, potentially in the emergency department, followed by ITU management. We'll talk a bit about the risk factors. This has come from, again, it came from NHS England and the Royal College of Emergency Medicine. Some of the data has also come from the Center for Disease Control in the US and the World Health Organization. So age is an independent risk factor. An increased age of more than 65 correlates with severe disease and high mortality. Patients in long-term nursing facilities and patients in care homes have a higher mortality rate. There have been cases in the UK, for instance, where patients in long-term nursing rehab or community homes have died. Recently, there were 23 deaths in one community home. So these are patients who are not being tested as well. Which I'm not sure is the correct option, but this is how it is at the moment in terms of resources. So this is age. Then people of all ages with specific underlying medical conditions, especially if these conditions are not well controlled, are all at risk. So patients with chronic lung disease, this could be your patients with bronchiectasis, with COPD, emphysema, all at high risk. Patients with moderate to severe brittle asthma, patients with existing cardiac disease, especially they're more prone to develop, they're obviously more prone to they can get myocarditis, as well as your normal cardiac issues. Your immunosuppressed patients are especially at high risk. So patients undergoing chemotherapy, patients who are smokers, patients who have undergone transplants, immune deficiency disorders, which could be your all the variety of immunodeficiency disorders present, HIV, the use of disease-modifying anti-rheumatic drugs, and long-term use of corticosteroids. Obesity has been identified as an independent risk factor as well for patients presenting with suspected COVID or positive COVID, especially with those patients who have a BMI of more than 40. Or your diabetic patients, these are also at risk. I'll talk a bit about the diabetic patients because you had a recent talk about it from the Royal College. Chronic kidney disease with patients on dialysis and chronic liver disease. So it's been interestingly noted in a number of centers in London that patients previously who have been type 2 diabetics are presenting with DKAs. So these are patients who have presented with, who are essentially diet controlled. Diabetics who are not on any medications are presenting with ketonuria, ketonemia, acidosis, and so a lot of the patients who eventually have COVID can be going into fluid overload. So it's quite difficult to tailor management for patients who are essentially in diabetic ketoacidosis. So some of the consensus coming out of England is to reduce the amount of fluids given to patients with diabetes, presenting with diabetes crisis in COVID situations. And some of the recommendations are to reduce fluid by half. So rather than giving a liter in the first half or start to give 500 mils of normal saline. Again, this is not gold standard. There is no science behind it yet. There is no evidence-based research behind it, but this is what people are practically doing in the US and England. So finally, take-home message is stay safe, use PPEs, consider every patient as positive until proven negative, follow institution guidelines, and the last thing is don't forget that all patients are not COVID patients. So do not miss patients who are coming in with your usual strokes, your STEMIs, your sepsis, your traumas. I've noticed a lot of people, including residents and other doctors, are focusing purely on COVID. So don't forget that there are your normal patients will also present. Your heart failures, your sepsis, anything which is unrelated to COVID will also present. So just be aware of those. And I have no conflict of interest. I've just said most guidelines I've put down here are developed as most of it is through Delphi. Anecdotal, some are based on trial and error, but evidence for best practice is increasing. So as healthcare providers and researchers learn more about the disease progression and treatment options, I'm sure we'll have better guidelines and more enhanced services available. Thank you. Happy to take questions if you have, or Anzal can share. Let's share the slides and the recording later on.
Hello, can I ask a question regarding the COVID presentation in pediatric age group? Is it same like adult or different presentation?
Yeah. So what has come? Yeah. So what has come out of lots of people, lots of again anecdotal. This has come out from Great Ormond Street in the UK and Sick Kid in Toronto. so it's still influenza-like symptoms. However, a presentation can be very atypical. So it's not always typical presentation for pediatric patients, especially if they're under 5 years of age. So any patient with a suspicion of COVID with pyrexia of unknown origin or no identified focus should be considered COVID positive till proven negative. However, as I mentioned in the talk, don't forget that your normal pathologies will present as well. Yes, so the answer is COVID presentation more or less follows the same adult guidelines. However, a lot of presentations which have been seen in Toronto and in some places in the UK are atypical presentations. So patients presenting simply with high fever, confusion, irritability without any obvious focus of infection or cause. So I hope that answers it. There are pediatric guidelines coming out from various places. I haven't shared most of them because the number of patients who, so the pediatric population is less affected, but saying that they have had a number of people who've had mortality in the UK and the US who are young children, as young as 1 or even younger. They've had a young and fit child in the UK who was age 13 with no pre-existing comorbidities, who was ventilated and eventually died. He also presented with influenza-like symptoms. So although the presentation can be variable, but be wary of anybody who presents at any age with a history of fever and with focus which you can't identify.
Thank you very much. Thank you, Doctor.
I hope that helps.
Thank you, Dr. Amar. I think we still have some time for a couple more questions if anyone is still has something to say. I mean, largely, at least for me, my takeaway was like Dr. Omar very concisely put it, is suspect everyone until proven otherwise. And that when the disease gets bad, unfortunately, it gets really bad, and it affects extremes of age. It affects them quite bad. You have to consider respiratory failure, and so even though the large majority may not develop symptoms, we are wary of the ones that do because they tend to have a very deteriorating course. The talk itself will be available to everyone to review later on, but you'll have this opportunity now to ask some questions live, and then we'll proceed to our next activity. So I'll give Dr. Omar a few last words.
I mean, just to add on as to what you said was, I mean, we've had patients who are ambulatory, who walk through the department, who have got low-grade fever, who are not hypoxic, and who are not tachypneic, and we end up doing a high-resolution CT chest on them, and these ambulatory patients have got bilateral ground glass appearance on CT. So you've got to be suspicious. So even, so I mean, even things like investigations, now they're going away from chest X-rays. So they are recommending to do, a lot of places are recommending to do high resolution chest CT, because so unless you've got a swab, for example, if you've got a swab from bronchotracheal lavage, from bronchoscopy, your sensitivity and specificity for a nasal oropharyngeal swab is 60 to 70%. So you still miss 30% of patients with a, you can have a negative swab, but actually you're still positive. So suspicion is high. A lot of places in the US are using CT chest as a primary modality of investigation. A lot of places are now moving away from doing chest X-rays completely, and some of the skilled operators are actually doing pulmonary ultrasound, where, I mean, lots of videos are available online. I can share with them if you want, and people are moving to do CT from, if you can do a CT chest within sort of a defined space of time, great. Otherwise, a lot of places are going to do where there are skilled point of care ultrasound operators. They're doing point of care ultrasound for lung fields. They look at 6. I mean, I'm not going into details, but they look at 6 different lung fields to see if there is any disruption in pleura. There's lots of videos and out there, and it would be useful for people who are skilled operators at point of care ultrasound to look at some of these videos and some of the ways you can do point of care ultrasound, because in what came out of the society in the UK was that you can do a point of care ultrasound in the hand of a skilled provider within 5 minutes. So you can have your suspicion within 5 minutes whether the patient is going to, it's a good tool for predicting morbidity and how sick the patient is. So if you can see obvious findings on point of care ultrasound, then patients are probably going to be quite unwell quite soon.
So we're actually going to be touching on this in the next lecture. But yeah, like you said about the 7 zones, 6 zones, it's actually up to 14 zones in some protocols, but more for the subpleural sensitivity that ultrasound has over X-ray, which basically is falling out of fashion. Just before we wrap up, I'm not sure if we've addressed this question. There's an in-chat question from Afshan Khatak, Dr. Omar. She mentioned that you mentioned in your talk that you're waiting for before intubation. What are the lowest SATs that we can safely tolerate?
So it is dependent on you, to be honest with you. So I have had, so this is all from personal experience. This is from talking to my colleagues working in critical care in the UK. Now, when it all started, they were intubating patients at a, if the patient has a SpO2 of 92% and high flow, they were intubating patients. They realized that these patients, so although they were saturating at 92% on high flow, they were otherwise hemodynamically stable. They were talking in full sentences. But they were still being intubated because that was the institutional criteria based on guidelines from NICE. However, now the so what they realized sort of a couple of weeks into the crisis is that they're running out of ventilators, so they have no ICU capacity. So they are not comfortable, but they are actually now tolerating patients up to 88%, and some places 86% on high flow, provided patients not confused, patients not hypovolemic or bradycardic or so on before ventilating. So it's institutional based. A lot of what I've gone through in terms of anecdotes from the US, especially from few of my colleagues working in New York, they were initially intubating at 92, and now they're tolerating up to 86% before intubating. And this is something which is not best practice, but this is in one sense, so my subspecialty is disaster medicine. So this is disaster medicine at its peak, to be honest, outside war zones, where patients are being, so this is essentially salvaging the best for what is available in terms of resources. They've had to do, because they were intubating far too many people in New York, they had to split ventilators to be able to support ventilations. So it is institutional dependent and what one is comfortable with. But generally, it's something which you've got to discuss within your colleagues in critical care and anesthesia. What's your comfort zone? There is no science behind it right now, but in the US, especially outside New York, there are some of my colleagues who are working in some of the big centers in Mount Sinai and some of the other hospitals. They are tolerating up to 86% on. So they are using, so although we'll talk about this later on in terms of not using non-invasive ventilation, they are using closed circuit CPAP with PEEP valves. So they are using CPAP to try and avoid intubation. It's not best practice, but they are doing it to try and avoid intubation with their. But just remember, in terms of the doctors and nurses and healthcare staff, they're using full PPEs in terms of hazmat suits. So the risk for them in terms of aerosol generating procedures is a little bit less. So that's why they are tolerating some of the CPAP. So they're using their full PAPR respirators before they're intubating anyway. I hope that helps. There's no science behind it.
I think that's a fair answer. And she's replied back in there as well. The best evidence we have is anecdotal. I think I agree as well. Almost everything is going to be managed on a case-to-case basis, and almost everything that we discuss here as well, as a disclaimer, cannot be definitive. We are only discussing what I can sort of recommend as a checkpoint in our knowledge so far. So thank you very much, Dr. Omar. That was a really great start to the talk and an overview for the day. We actually have a short break now until about 10 a.m. I've sent out a link in the in-chat window for anyone who can read it. You can follow this for a video that's going to supplement Dr. Omar's talk, and it just gives you an overview of what the Italians saw. As we know, they suffered through the pandemic in the worst of ways. So the ICM conference held a webinar, and that's a small excerpt that might help academically speaking. So we're going to reconvene at around 9:55, and I will see you all then. Thank you very much, and some of you can stay online and you can view it in the background. The session will still remain live. Thank you.
Thank you, Anzal.
All right, everyone. We will resume our lecture sessions shortly. I hope everyone had time to have a look at the video from the ESICM webinar. But in the meantime, I'd like to introduce our next speaker. Dr. Ruqayya Lafifi is going to be presenting the next topic, which is investigative modalities for COVID-19 patients. Ruqayya is currently a third-year emergency medicine resident with us at the Zayed Military Hospital in Abu Dhabi. She is a colleague of mine and a quality team member for the Emirates Society of Emergency Medicine. Dr. Ruqayya has a vested interest in sharing updated knowledge in developing teaching tools. In particular, she continually strives to incorporate the newest research into practice. And I'm just going to give her the floor right now. Along with this, yes, she loves to talk about ECG. She loves to discuss acute metabolic disorders in the ED, which is another topic for another day, and is an advocate of point-of-care ultrasonography in the ED. So, Dr. Ruqayya, glad to have you with us.
Assalamualaikum. Good morning, everyone. I'm Ruqayya Lafifi. Thank you, Anzal, for introducing me. So, for the next 30 minutes, I will be talking about investigation modalities of suspected COVID patients. Since the signs and symptoms of COVID-19 are largely atypical and the investigation findings are largely variable, so I would like to concentrate more about what we know to be true. I'll talk a little bit about first and pitfalls using laboratory findings, just X-ray, CT scans. I'll talk about point-of-care ultrasound, how to use it, and what are the findings, and I'll try to show you some videos. Also, I'll talk about the diagnostic test of COVID-19, as well as the sensitivity and specificity of each test. Let's start with laboratory first and pitfalls. So looking at the evidence from China, Europe, and some other countries that's coming out, the things are not specific, but have the highest yield. CBC will show leukopenia, lymphopenia, leukocytosis. Although lymphopenia appears to be the most common to be seen, and it's seen in 80% of COVID patients. Thrombocytopenia also decreased in all cell lines being seen, but rarely the platelet will be below 100. So if the platelet below 100, the lower the platelet means the poor prognostic sign. There is also elevated lactate dehydrogenase, as well as ferritin. It's common to be seen, which is a bad prognosis as well. Patients can have elevated aminotransferase as well, and many patients will have a transaminitis, in which they will start with the GI symptoms, and you can see a slight increase in their liver function. Some patients will have D-dimer along with more severe lymphopenia, so it's associated with bad mortality, with high mortality. DIC also may evolve over time. It's correlating with poor prognosis as well. Some patients can have elevated troponin, which is a strong predictor of poor prognosis, a critical illness, and ICU admission and death. So according to Chinese study, 22% of patients who were admitted to ICU had elevated troponin versus 2% with non-elevated troponin. Of those patients, 59% that died had elevated troponin versus 1% with non-elevated troponin. Some physician will do procalcitonin. It's expensive, it's non-specific, and most of the patients, or 95% of them, will have it negative or less than 0.5. So elevated procalcitonin suggests an alternative pathology, or it can suggest a superimposed bacterial pneumonia. So many patients with pneumonia will have normal serum procalcitonin on admission. However, those patients requiring ICU, they are more likely to be elevated later on. So CRP is used to track the disease. It rises with COVID-19 patient and increases with the severity of the disease and prognosis. So patients with severe respiratory failure and the normal CRP, you should consider a non-COVID cause and other diagnoses such as heart failure. We have something called delayed cytokine storm, which Dr. Amar mentioned about it earlier in the morning. It happened around day 7, 8, 9, 10, in which the rise in CRP and ferritin with more lymphopenia leads to rising inflammatory effect that's giving the features of bacterial sepsis, which will lead to delayed compensation of the patient. So what are the workup we're doing for COVID patients? We will do at admission, baseline, HIV-1 and 2 antibody and antigen. We can also add G6PD if we're considering a chloroquine and the treatment. We will do at the baseline and every 24 hours cytokine panel. As we mentioned, the patient will have cytokine storm. At the baseline and every 12 hours, we will be doing CRP, procalcitonin, ferritin, lactate dehydrogenase, BMP, troponin, D-dimer, fibrinogen, and PT and PTT. We will also be doing ECG at baseline and daily if the patient is not already on telemetry. We're done with the laboratory finding. Let's move on to radiological pearls and pitfalls. Starting with the chest X-ray. So chest radiograph may be normal in early or mild disease, and the patient might look thicker than the radiographic imaging. Sensitivity of chest X-ray is only 59%, and the retrospective study of 64 patients in Hong Kong with documented COVID, 20% of them didn't have any abnormality on chest X-ray at any point during the disease. So the problem with the chest X-ray, people will have symptoms before they show some findings in their chest X-ray. That made a lot of physicians move out to do chest CT scan. So if the chest X-ray is positive, mostly it will show bilateral, peripheral consolidation, or what we call reverse batwing. It's important to run your eyes up the side of the lung, mostly the lower lung zone distribution. Sometimes bilateral central consolidation, which is more classic of batwing picture, which is hard to be differentiated from pulmonary edema. So lung involvement increased over the course of illness, with peak severity in around day 10 to 12 after symptom onset. And finally, it will show the typical ground glass opacity of ARD patient. So If the chest X-ray was positive, and the patient is highly suspected history of COVID contact, and with signs and symptoms of COVID, you don't need to move on and do chest CT scan. Chest X-ray is enough. So the chest X-ray findings from the most common to the least is lower loop location, interstitial changes, bilateral location, multifocal, ground glass opacity only 18%, and effusion and lymphadenopathy are not common. This is a picture of chest X-ray of COVID patient showing the back wing appearance. In this picture, it's central, but some X-rays will show peripheral infiltration. This is another picture of COVID-19 chest X-ray. It's multifocal or ground glass opacity, diffuse all over bilateral line. So, what are the features of chest X-ray that make you think of other differential diagnoses if you saw them in the X-ray? Pleural effusion are not common in COVID-19 patients, so consider alternative pathology if it's present. Small nodules, as well as capitating mass and markedly enlarged lymph nodes. Now we're done with chest X-ray, let's move on to the CT scan. CT scan have more sensitivity, which is 86 to 97%, but only specificity of 25%. So although some chest CT scan finding may be characteristic of COVID-19, still there is no finding that's completely ruling out or end the possibility of COVID-19. So we are looking for bilateral ground glass opacity, usually peripheral or at the bases as we mentioned, but it can be anywhere, plus or minus consolidative abnormalities, consistent with the viral pneumonia. The number of lung segment involvement increases with more severe the disease. Less commonly, we will see a crazy paving pattern. I'll try to show you pictures later on. So a crazy paving pattern is the ground glass opacities that have superimposed the little septum between the alveoli, leading to pleural thickening and pleural effusion and lymphadenopathy. Later in the disease, the consolidation with air bronchogram can be seen, which is it can be seen of any type of infection disease in the lungs. So CT findings from the most common to the least: bilateral ground glass opacity 91%, fine reticular opacity and 56%, vascular thickening and 59%, diverse sign, less likely to be central and peripheral distribution, air bronchogram seen in 14%, pleural thickening in 15%, pleural effusion 4% only, and lymphadenopathy in 2.7% only. So, however, chest CT abnormality have also been identified in patients prior to development of symptoms and even prior to detection of viral RNA from upper respiratory specimens. Among patients who clinically improve, the resolution of radiographic abnormalities may lag behind improvement in fever and hypoxia. This is the picture of a CT scan of COVID-19 patient. As you can see, the infiltration is clearly on the periphery, as we mentioned before. This is another picture showing the types of infiltration. Ground glass opacity here. Here the crazy paving pattern with the pleural thickening. Here we can see the consolidation with air bronchogram. I hope it's clear for all of you. So what are the radiographic pitfalls? You should be careful how to use radiographic like chest X-ray or CT scan, because for every patient you're going to do them, You should shut down those things and clean them up so you don't potentially spread the infection. So imaging doesn't make the diagnosis of the disease, but it defines the extent of the disease, and it maybe actually suggests an alternative diagnosis. So the American College of Radiology recommends not to use just CT scan for screening or diagnostic material of COVID-19, and it recommends serving it for hospitalized patients when needed for management. Now let's start to talk about ultrasound. I'll be talking about ultrasound of lungs and heart. Starting with the lungs, many people are not facile with ultrasound, but it seems that there is an ER rule of point-of-care ultrasound in evaluation of patients of COVID-19 lungs. So why? Because ultrasound is faster than the RT-PCR in terms of time. Therefore, the sickest patients who deteriorate requiring hospitalization or ICU admission, people on ARDS, seems to be the first step, but of course not for all patients. So you can watch and follow the changes of COVID pneumonitis, either it's worsening or improving. You can also rule out other conditions or complications as pneumothorax. So the sensitivity of ultrasound is not clearly identified. It depends on several factors, for example, disease severity, if the patient is obese, a scanning technique, if the physician is used to do ultrasound, and all these things. So it's roughly between CT scan and just X-ray sensitivity. There is no yet solid data. So in order to achieve sensitivity, attempting to visualize as much lung tissue as possible. The specificity is extremely low because patchy lines or consolidation can be seen in any pneumonia or any interstitial lung disease. I will start with the scanning technique using the linear probe or whatever preferable for you. I prefer linear probe because it obtains high resolution of the pleural line. Trying to do multiple sites starting from top as here shown in the picture, down to the base of the lung in both directions, vertical and horizontal. So what we are looking for fluid, consolidations, focal B lines more than 3, vertical lines, which is typical in COVID-19 patients. I will show you videos later on. This is another picture showing the technique. So we are going systematically in the anterior surface of the lung, right to left, from up down to the base of the lung. Don't forget to do the axillary line, the same technique, so you don't miss any part of the lung, as well as the back, the posterior surface of the lung. Try to cover as much as you can from the lung surface. So important principle is air fluid ratio. As we go from A to B, we're going from 100% air to 100% fluid. So A line is the lung without sliding, which is the barcode. We can see it in pneumothorax. A profile, which is the lung with the normal sliding, as here. B lines or B profile means interstitial syndrome. C lines, which means the consolidation, and P, which is for pleural effusion or 100% fluid. So as the disease worsens, we're going from air to fluid. And as the disease improves, we will go from fluid up to air again. are the ultrasound findings? The ultrasound findings of the lung correlates very well with the CT scan. So if the CT scan showing mild ground glass opacity, first we will be able to see a scattered V line in ultrasound. The more confluent the ground glass opacity, it correlates with V lines thickening of the pleura, which leads to waterfall sign. Then the more severe the disease, subpleural or small peripheral consolidation will be showing. In more severe form, the volume of consolidated lung increases. But in COVID-19 patients, we never see, or it's very rarely to see pleural effusion, such viral pneumonia. As I mentioned, we will move from air down to consolidation, but we will not reach the pleural effusion. This pictures of B9 showing you more than 3 B9, which is abnormal or pathologic. The waterfall sign, and this picture showing you the consolidation, a small consolidation, and then the last one showing a large consolidation. Another picture of patchy multiple line irregular pleural surface, which is suggesting consolidation. Now I'm going to show you videos of normal lung surface first and then the abnormal lung surface. You can nicely see the pleural sliding here. And this is the posterior surface of normal lung. As you can see, the liver, the diaphragm. I hope it's clean. I hope it's clear to everyone. Here you can see single B line. And here the confluent B line. This is the subpleural consolidation. Script lesion. And finally, consolidation with air bronchogram. So we're done with lung ultrasound. Let's move to ultrasound of the heart. So try to lower the threshold for echo. I prefer using echo-probe or curvilinear, whatever you prefer. Why? Because early echo in the high-risk patient or patient with risk of heart failure, it's a very good predictor of adverse outcome. It can detect COVID-19 related myocarditis, as it was attributed as the cause of death in 7% of patients, and it's a contributing cause of deterioration in 33% of patients. So looking at the ejection fraction, because it can go as low as 44% and 30%. So study showed that acute heart failure reported in 23% of patients with COVID-19 and in 25% of patients that died versus 12 with no heart failure. Now let's move to diagnostic investigations. So patients who meet the criteria, which we talked earlier in the morning, should go for testing of SARS-CoV-2, which is the virus causing COVID-19. And in addition to testing of other respiratory pathogens, such as viral panel, including influenza, RSV, and other, atypical PCR panel, including mycoplasma, chlamydia, legionella, And if the etiology of severe pneumonia is not yet identified, we can add other investigations such as Legionella urinary antigen, mycoplasma titers, TB culture, and PCR, bronchoscopy, biopsy, and don't forget the opportunistic pathogens in immunocompromised patients. The PCR swab, CDC recommends collection of nasopharyngeal swab, nasal mid-turbinate from both layers. So the viral level from upper respiratory specimens appears to be higher soon after the symptom onset, comparing with later in the illness. So try to obtain lower respiratory tract specimens if possible. And also expectorated sputum should be collected for patients with a productive cough, but don't induce sputum. Also, the lower tract aspiration or bronchoalveolar lavage should be collected from patients who are intubated. 75% will show positive within 96 hours of exposure. So the sensitivity of PCR between 75 to 80%, but the specificity is high, it's 90.63%. The single negative PCR doesn't exclude the diagnosis, especially if it's obtained from upper respiratory tract, as I mentioned, and early in the disease. So if we have false negative of upper respiratory specimen, but the patient is still suspected, highly suspected of having COVID-19, the test should be repeated within 2 to 3 days later. If possible, obtaining lower respiratory tract specimens, maybe it has higher viral loads and it's more likely to yield positive than the upper respiratory tract. The highest rate of positive viral RNA tests were reported from first bronchoalveolar lavage, 95% were positive, the sputum, 72% was positive, and oropharyngeal swab, only 32% positive. So one study of 21 patients with mild illness, no hypoxia, 90% of them had repeated negative viral RNA test on nasopharyngeal swabs. But by day 10, after the onset of symptoms, they tested positive for longer in patients with more severe illness. And another study of 137 patients who survived COVID-19, the median duration of viral RNA shedding from oropharyngeal specimen was 20 days, so it ranges between 8 to 37 days. The conclusion: detectable viral RNA doesn't always correlate with isolation of infectious virus, and there may be a threshold of viral RNA level below which infectivity is unlikely. So as described above, infectious virus wasn't detected from respiratory specimen when the viral RNA less than 10 copies per ml. Transmission of SARS-CoV-2 from asymptomatic individual or individual within the incubation period was also described. SARS-CoV-2 RNA is detected by a reverse transcription polymerase chain reaction, and it generally confirms the diagnosis. Last but not least, the staff should be trained on sample collection, and all specimens should be regraded as potentially infectious. I'm done with my presentation. So anyone have any question?
Thank you very much, Ruqayya. We had a comment in the in-chat from Dr. Naeem Tusi. Welcome, Dr. Naeem. And he mentioned how one of the main challenges is to separate suspected from confirmed, and to a degree that's very relevant to your talk as well. That ultrasound radiology, they're useful for confirming and follow-up, but they don't really help with the separating of suspected from confirmed. I mean, honestly, that's a bit of a split opinion on that, but I think at the very least you can risk stratify with using all of these diagnostic modalities. I think you've done a pretty good job of explaining what findings you could potentially see using those three main modalities. And I guess that's only going to be a useful guide. Do you have any more comments on this?
So as I mentioned before, it's not like radiographic imaging is not a diagnostic tool. It guides you. So you should take a good history, depending on the history, sign and symptom of the patient, and supported by your diagnostic finding, like evidence on chest X-ray, finding on CT scan. It supports your diagnosis. It supports your suspicion, because sometimes you don't have like the, as I mentioned, the upper respiratory or nasopharyngeal swab will not show you in early in the symptom or early in the disease, will not show as positive. So with the history, confirming it with supporting with the imaging, you can kind of separate the patient, suspected patients.
I think that's very well put. Thank you very much, Dr. Ruqayya. Does anyone have any more questions? All right. So we're going to move on to the next talk, and this is going to be by Dr. Mohammed Al-Amin Abdurrahim Salama. And I'm proud to say he's again one of our first year residents, emergency medicine at Zayed Military Hospital in Abu Dhabi. Mohammed Al-Amin has a vested interest in practicing and sharing knowledge as well, and he's particularly proficient when he's diving into literature and research. Though he may not claim it, and he's quite humble, he is very adept at dissecting different information and performing evidence-based medicine. However, for some strange reason, he claims that his field of interest, no offense, is sports medicine and public health. So without further ado, I'd like to introduce Mohammed Al-Amin, presenting on PPE in COVID-19 patients. Welcome.
Thank you very much, Dr. Anzal, for the nice introduction. I would like to extend my thanks to all the speakers and audience, and it's my pleasure to be a part of this virtual academic program for COVID-19. And today I'll be talking about the personal protective equipment that should be used when dealing with patient who is suspected or confirmed to be having COVID-19. Also, I will differentiate between the different types of masks that's being used. I will shed some light also in the air purifying respirators. And in case we have depleted supplies of the masks, but in particularly the N95 respirator, there is some consensus from CDC that the N95 mask can be reused. And then eventually we're going to talk about the donning and doffing of PPE briefly. So as we can see here from this picture, as per the CDC guidance, the minimum PPE that need to be worn while caring for someone who is suspected or confirmed to have COVID-19 include the 1 pair of clean non-sterile gloves, the isolation gown, and the eye protection, which is either the face shield or the goggles. And as per the CDC guidance, it's preferred to use the N95 respirator or higher respirator when caring for all patients suspected or having the COVID-19. However, recently they have accepted to use the face mask as an alternative if not present. And the use of N95 respirator or higher respirator particularly should be used when dealing with an aerosol generating procedures that is going to be discussed, inshallah, in the next presentation by Dr. Tasneem. So there is always a lot of confusion when evaluating a patient with upper respiratory tract symptoms, and whether to use the surgical mask or the N95 mask or respirator. So I have made this comparison and summarized them in this table, the surgical mask versus the N95 mask. I also have added the PAPR, which is the powered air purifying respirator. So basically, the surgical mask, as we know, is a fluid resistant, and it protects against the larger droplets, splashes, or sprays of bodily fluids. And the N95, it has the extended protection against the smaller particle aerosols and the larger droplets as well. And the Barber advantage is that it is reusable, and it has replaceable filters or cartridges, and it also provides additional protection against the gases and vapors. As per the surgical mask, as we know, they are loose fitting and they doesn't require fit testing, while the other respirators such as the N95 and the Barber, they tight fitting and they require the fit test and the user shield check. The surgical mask simply they does not protect from the smaller airborne particles, while the N95 filter out at least 95% of the airborne particles, and the Barber, when used with the HEPA filters, has the capability to filter at least 99.97% of the airborne particles. Additionally, it has low breathing resistance, so it's more user comfortable. Regarding the leakage, we know that the surgical mask might lead to leakage around the edges of the mask. However, the N95 and the Barber, when properly fitted and donned, they provide minimal leakage around the edges. This is another simplified comparison between the N95 and the surgical mask. As we know, the N95 reduces exposure to smaller particles, filters out at least 95 of the airborne particles, and it's tight fitting and allows minimal leakage. While the surgical mask, on the other hand, they are fluid resistant, they protect the wearer against the larger droplets, and they does not protect against smaller airborne particles. Additionally, they are loose fitting and allow for leakage around the edges. What about the cloth masks or the masks that are made of cloth? Uh, Basically, the WHO opinion said that they are not recommended under any circumstances to be used, but CDC agrees that this mask can be used in public setting where social distancing measures are very difficult, such as the groceries and pharmacies, especially in communities where the transmission has been found to be very risk of transmission has been very high at these communities. So in the UK, they are calling the respirator protection masks the filtering piece particles, and they have the N90, the FFP2, which is equal to N95, which filters not less than 94%, and they have the FFP3, which has the capability to filter it is not less than 99%. And actually, UK recommends the FFP3 respirator for the use during the high-risk procedures. However, it does state that FFP2 can be used if the FFP3 are not available. And the FFP3 is identified by the red straps, usually. And this slide shows us the different types of air purifying respirators in addition to the N95. This is the elastometric full face and half face piece respirator and the Barber. All of them are reusable and they can protect against the gases, the vapors, and other particles as well. And however, the Barber advantage is that it has a battery powered with a blower that pulls the air through the attached filters or cartridges. And in this slide, I'm going to differentiate mainly between the N95 and the Barber, which considered more higher level of respiratory protection. The N95, as I mentioned earlier, it does not provide protection against the gases or vapors. The Barber and the other respirators, they provide that. And the Barber, as I mentioned, the advantage of it is that it's battery powered with blower that pulls the air through the attached filter or cartridges. It provides as well an eye protection. And most importantly, it is reusable. This is the Barber. And here we can see an statist intubating a patient with the use of the glidioscope while using the Barber. This question I found it in the WHO website in the question and answer section. So what personal protective equipment should be used by healthcare workers who are performing the nasopharyngeal or oropharyngeal swabs on patients with suspected or confirmed COVID? Of course, initially we need to have a mask. Either the preferred is the N95 mask, or if not available, we can use the surgical mask. And then in addition to the eye protection, the gown and gloves. Interestingly, the WHO has said that uh, although the nasopharyngeal or oropharyngeal swabs they might induce fits of cough. These fits of cough are generated through the nasopharyngeal or pharyngeal swab. They are not producing aerosol, and they are advocating for the use of surgical mask. However, there is a lot of new evidence coming that the nasopharyngeal or oropharyngeal airways they carry at least a minimal risk for aerosolization, and it's better to use the N95 mask. Can disposable surgical face masks be sterilized and reused? They say that no, they are not intended for a single use. However, they can be used over the course of many patients. If you are, for example, caring for the same cohort of patients at the same time, you can use them for extended period. But once you are doffed them, you don't have to wear them again. So, what is the evidence that COVID-19 PPE equipment should include shoe covers? This is from the community of evidence-based medicine. The recommendation for PPE when caring for COVID-19 patients do not currently include shoe covers, as we saw initially in the slide for the CDC guidance, in accordance with the WHO as well as the Canadian guidelines. However, there are no relevant published trials. The General Occupational Health from US advises recommend shoe covers when there is a risk of splashing, so they recommended further research. And this was based on a study in a COVID center in Singapore, where they initially included the 3 healthcare workers, and they identified one positive COVID-19 sample from the front of the shoe cover, and then one of 3 samples, and then they extended the research to include 30 healthcare workers, and they found none to have the positive COVID-19. However, a nice and a very interesting one coming from China was published in the CDC. It was conducted in Wuhan in a hospital with a capacity of 15 patients in the ICU and 24 patients in the general ward at the Wuhan hospital, one in the of the hospital in Wuhan. Basically, they took air and service samples, and these samples included the samples from the floors, from the computer mice, from the trash cans, and from the sick bed handrails. And interestingly, they have found that the rate of positivity was relatively high for the floor swabs samples, around 70%. For the general ward, it was 15.4%. And there was 100% rate of positivity from the floor in the pharmacy, where there were no patients at that place. They typically used to send the nurses or the porters to get the medication for the patient. And it's very important to mention that half of the samples from the soles of the ICU medical staff shoes tested positive. Therefore, the soles of the medical staff shoes might function as a carrier, and it's better recommended to use the shoes cover, especially when there is high risk of contamination and cross infectivity for the patient. Now, the CDC have advocated for this use of reuse of N95 respirator, of course, while maintaining the health and maintaining the safeguarding, I mean, the healthcare workers while conversing supply. And one of the measures that they have advocated for is the reuse of N95 respirator. However, its use should be controlled in accordance with the infectious disease policy, and it should follow a strict rule to be reused. So they mentioned that the reuse can occur under the following condition. The mask should be used by a single user. It should be covered by a full face shield or a surgical mask over it. It should be kept in a clean, breathable container between the uses. And it's recommended to ensure appropriate storage, labeling, separate containers, and hand hygiene. And always to use the gloves and practice hand hygiene and avoiding touching the mask. And do not reuse the N95 and discard it immediately if it is contaminated with any fluids coming from the patient, such as the blood, respiratory, or nasal, following the use during aerosol generating procedure or close contact with any patient co-infected with disease requiring contact precaution. If the straps are stretched out so they are not providing effective seal around the face, if the nose piece or the other fit enhancement measure are broken, so if the mask is no longer functioning and it's not comfortable for the healthcare provider. And if the respirator has been used more than 5 times or has been used continuously for 8 hours, we should not reuse the N95 mask. Moving on to the donning and doffing of the BBEs, it's worth mentioning that the systematic approach of using the BBE is much more important than putting on or taking off the BBE, and that should follow the local Department of Health policies or anything or the guidelines of the appropriate of the provided by the hospital. And I'm sure most of the audience here they have been through training for the BBEs, so I'm not going to talk about this mainly. But it's very important to use safe work practices to protect yourself and limit the spread of contamination. And it's advised to keep hands away from the face always and limit the surfaces touched, and to change the gloves when torn or heavily contaminated, and to perform hand hygiene always. And for the doffing, as we know, it's a very high risk process. It's more risky than the donning process. And it's advised that should be done in front of the mirror or in front of another colleague so that they can guide you to do it in the appropriate way. And these are the steps. We can start either by removing the glove and then going to remove the gauge or face shield, or we have the other example, which we remove the gloves along with the gowns and then move on. I'm not going to discuss these steps. And here I've added this YouTube video that you can see the appropriate donning and doffing of the PPEs as per the CDC guidance. Now the link will be added to the chat. And you can simply type the intake personal protective equipment for COVID-19 and watch that. And you might skip the first 5 minutes as they are talking about the disease transmission and this stuff, and then they will start talking about the donning and doffing process. So last but not least, every month the frontline health responders around the world need these supplies and more to protect themselves and others from the COVID-19 every month. It's estimated that around 89 million masks needed, 30 million gowns, 1.6 goggles, 76 million gloves, and 2.9 million liters of the hand sanitizers. And the prices actually are surging of the personal protective equipment after the outbreak of the COVID-19. And they estimated that the surgical mask has increased sixfold. The N95 mask prices has increased around, has actually tripled. And the gowns, isolation gowns, prices have doubled at least. So the WHO is saying that to meet global demand, it is estimated that the industry must increase the manufacturing by at least 40% to meet this demand of the personal protective equipment. And my take-home message here is that whenever you are donning or putting on your PPEs, think first of all, is it an aerosolizing procedure or it is not aerosolizing procedure? If it is aerosolizing procedure, the minimum the minimal PPE that you need to put on is the N95 respirator or higher, such as the PAPR, plus your eye protection, plus your gown, plus your gloves. So you will take the airborne precaution. If everything else, we still recommend the N95. However, it's not available. You can use the surgical mask for the as per the mask, and then you might and you need to put on your eye protection, your gown, your gloves, the droplet and contact precaution. And doffing, as I mentioned, is a high-risk procedure, one of the highest risks for self-contamination. First, you need to take off your gown and gloves before you touch anything around your face. Second, you need to wash your hands well before you touch the PPE involving your face. And when taking off your mask, handle the straps behind your ears and never, never, ever touch the front of the mask because it's associated with high contamination risk. And the N95 respirator may be reused to safeguard healthcare workers while conserving supplies. And this is the end of my presentation. This is my references. And stay safe, wear your PPEs appropriately, and hopefully we can stop the spread of this coronavirus. Thank you everyone for your listening and for joining us in this presentation. Any questions?
Thank you very much. Yeah. Any quick questions for Dr. Amin, and then we'll move to the next one. You can refer to the in chat. So Dr. Saeed has mentioned whether or not we can use N95 for can we disinfect these masks and possibly reuse them. Do you have any comments on this, Amin?
The N95 mask, yeah, as I said, in case we have depleted supplies of the N95, we can reuse them, but however, their use should be restricted and should follow a proper control, especially following the CDC guidance as well as the local infectious disease guidance as well. So it's mentioned here, as I said in the slides, they should be used by single user, and they should be covered by the full face shield or surgical mask over them, and we should keep them in a clean, breathable container between the uses, and always we should ensure appropriate storage, labeling, separate containers, and hand hygiene. And when labeling, we should not write in the mask itself, but we might write in the straps, or we might write in the container itself. And always we should use the gloves and practice the hand hygiene when you reusing the N95. And we should avoid touching the mask, and we should not reuse them if they are contaminated, or if you have used them for the aerosol generating procedure or close contact with someone who is co-infected with the disease that is requiring contact precaution, or if basically they are malfunctioning, they are not allowing for appropriate face seal, or they are broken, or they have been used more than 5 times, or they have been used continuously for more than 8 hours. This is regarding the reuse of N95 masks. Any more questions?
So thank you, Amin. I mean, in the interest of time, I think we'll wrap up now and move on to Dr. Tasneem's lecture. But the other questions, basically talking about specifics of conservation. Now, these are gonna differ based on where you are and where your locality is, and of course, based on the resources that are available in that country. However, as a general rule, we should err on the side of caution. So whatever best you can do to protect yourself, especially during procedures, which we're going to discuss right now, is probably best, whether that's a full helmet or a PAPR or something. Whatever you have, use it in the best way. And this is going to depend on your local guidance, recommendation, and your best clinical judgment. We have to protect ourselves first so that we can help others. And moving on to the next lecture, just so that we can transition gently into aerosol generating procedures, we have Dr. Tasneem Mohammed Saeed, and she is another one of our star residents from our first year emergency medicine program in Zayed Military Hospital. Dr. Tasneem has a special interest in integration of technology and medical education, and she works very well on implementing digital art into educational activities. And I think after this presentation, you guys are going to be able to attest to that. Just a disclaimer, all of these graphics, for the most part, have been made originally by her. So that can give you an idea about how invested she is in multimedia forms of presentation. So thank you very much, Dr. Tasneem, for joining us. And I'll leave the floor over to you.
Thank you, Anzal, for hosting this, and greetings for our respected audience. And thank you all for joining and giving us the opportunity to share this experience with you. As highlighted earlier, I'll be discussing the aerosol generating procedures. Sorry. And this was a summary of my presentation about aerosol generating procedures. Thank you for listening. And any questions? Unfortunately, I can't hear you laughing. If you're laughing, this was a joke. I hope you got it. If not, this would be the first joke ever to be explained throughout a formal presentation. So to help you get it, I'll be answering mainly 5 questions about aerosol generating procedures, starting with what's an aerosol, and then how far can aerosol travel? Is COVID-19 an aerosol or a contact transmission? How is aerosol generated? And finally, a list of aerosol generating procedures from high risk to low risk. Okay, here we begin. So the literature defines aerosol as particles suspended in air that contains pathogens. Now it can be fluid particles or solids. And then there is an ongoing debate on how to classify them. So most literature use the size classification. So aerosols are any particle less than 5 micrometer in diameter. And then there is the a classification according to where they settle down in the respiratory tract. So again, aerosols are classified as respirable particles where they settle down in the lower respiratory tract. And then there's the inhaled particles that settle down sooner in the upper respiratory tract. But then if you think about it, it also goes back to the size, as respirable particles are defined as any particle less than 10 micrometer in diameter. So all aerosols by default are respirable, but not all respirable particles are aerosols. Now, the logic behind this is that small size particles follow air diffusion. So they can be suspended in the air and they can travel as far as and low as the level of the alveoli. And this makes them airborne transmission. Now, on the other hand, there are the droplets. Droplets can be further divided according to the size into small droplets ranging from 5 to 20 micrometer in diameter. And then there's the large droplets, any particle more than 20 micrometer in diameter. Now, droplets are only fluids, and heavier size droplets tend to follow gravity rather than air diffusion. So they tend to settle down sooner in nearby surfaces, making them transmitted by contact transmission rather than airborne. And then again, remember that according to where they settle down in the respiratory tract, respirable particles are less than 10 micrometer in diameter. So droplets can either be inhaled or respirable. Being a smaller size respirable and larger size inhaled particles. So you can think of it in a nutshell as a spectrum from aerosol to small droplets to larger droplets. And as you're moving up the scale, you shift from airborne transmission to contact transmission rather than a fixed cutoff point. Moving to the second question, how far can an aerosol travel? And I believe that this was partially answered by the previous slide. However, there is a common concept shared by the infection control parameters saying that aerosols can travel up to 2 meters, and this is regarded as the safe distance from the patient. But can we find a citation for this? Not actually, because there is no clinical evidence. However, it seems logical that smaller size particles travel farther and can suspend in the air for a longer time. But this is the point. It's all about logic and it's all about scientific concepts. So science can give you an example that a certain size particle or a particle of X size can travel for a Y distance and can get suspended in the air for a Z time. But this is not the scenario in the clinical practice, as it can be influenced by other factors, including the initial velocity. So for example, with coughing or sneezing, the particles get propelled farther up to 6 to 8 meters. Another factor is the temperature. As in high temperature, even the largest droplet can evaporate and shrink in size and form what's called droplet nuclei. And droplet nuclei can travel farther and suspend longer in the air. Finally, but not conclusively, the humidity. As with humidity, there is a potential for increase in the initial size of the droplet, actually. Moving to the third and most crucial question, is COVID-19 airborne or a contact transmission? Now, I think you already know the answer for this, and if you're thinking we're not sure, you're right, as it's a moot point. Just as anything related to COVID-19 currently, there is no much of evidence. and all current data is based on how MERS and SARS used to behave back in their pandemics. So here's an overview from a systematic review of transmission of respiratory viruses, and it summarizes the clinical evidence based on experimental data and infection control guidelines, including the Red Box, CDC, and UpToDate. And from the first glance, it's obvious that contact transmission is dominating, with only CDC recommending aerosol precaution for SARS virus. Now, on the other hand, there are several studies that better explains the expansive pattern of MERS and SARS transmission in their pandemic, rather than just random transmission by contact. So the first couple of studies, they've shown that there is a link between, or there's an association between the hospital ventilation system and the pattern of transmission of these viruses. The second couple of studies have shown that there is a link between the aerosol generating procedures and the SARS and MERS transmission. Now, as we mentioned earlier, CDC finally recommended airborne transmission precautions. So it's worth mentioning that all of these studies are weak, quality and quantity wise, and that aerosol generating procedure studies were done retrospectively, which means it's hard to determine which has led to what. I mean, if you're doing CPR, you're also doing bagging and intubation at the same time. So how possibly can you determine which procedure has led to the aerolization and infection? So this goes in support with airborne. And as a conclusion, a better answer would be safe and adopt extra precaution rather than being not sure. So as for now, it's regarded as airborne transmission. Now we're halfway through, and before I explain the aerosol generating procedure, we have to understand the concept of aerosol generation at the beginning. So aerosol, to be formed, there should be an air flowing over a liquid layer for it to be able to evaporate the fluid and carry out the fluid particles with it, and then spread it through air. Okay, and there is a lot of factors that can alter this process significantly. Viscosity can alter the process. With the increase of viscosity, there's increase in formation of aerosols. And here emerges a very significant clinical implication, where some physicians were discussing the use of surfactants in the treatment of the COVID-19 lung disease. However, as per this discussion, it clearly shows that surfactants are potential for forming aerosols. In contrast, normal saline nibs has been shown to be safer in terms of generating lesser amount of aerosols, actually. Finally, what's an aerosol generating procedure? Basically, it's any procedure capable of generating air to form an aerosol. So this can be either directly through introducing air into the patient's airway, or indirectly through inducing the patient to cough or sneeze. Now I'll be listing the procedures from higher to lower risk, beginning the list with bag mask ventilation. Now, science have been shown that 20 to 30 centimeter leak can be, there could be 20 to 30 centimeter leak from the bag mask ventilation, and it's all about a good grip. So a good mask seal and HEPA filter can reduce or minimize the risk of aerolization. Intubation, in fact, it's not an aerosol generating procedure of its own, because remember, you need an air to flow over a liquid layer. So passing a tube through the vocal cord shouldn't be a problem unless the patient coughs or there is bagging going on. So the current guidelines recommending the intubation to be done by the most senior and to avoid bagging, and if applicable, using video laryngoscope to maximize the distance between the patient and the physician, and then minimize the number of staff. All of this to minimize the risk of aerolization or infection through aerolization. Fine, and NIBs. NIBs are actually, and interestingly, are done for this purpose. It's already done to generate aerosols, medical or drug aerosols. And there's an argue that drug aerosols are actually heavy and they stick quickly to the mucous membrane. So there's a debate that nebulization it can produce aerosol, but it's not infectious. However, it's still regarded as a high-risk procedure, and if possible, it can be replaced by MDI or performed in chambers. Open suctioning, it's not actually about aerolization, it's about exposure or increased risk of exposure, because it actually reduces the aerolized material if it's done prior to intubation. So again, good ventilation can minimize the risk of open suctioning. Non-invasive and high-flow nasal cannula. Although they're lesser risk than the invasive and intubation, they're still regarded as high-risk procedures. And there are two bottom line theories. One is that the backflow of the contaminated air is more of coughing rather than leak, although leak has been shown to be from 50 to 100 centimeter. And the other theory is that the higher the flow needed is the sicker the patient, which means the higher the viral load. Again, negative pressure room can minimize the risk of infectious aerolization. CBR, unfortunately, there's no enough evidence, though compression is a potential process for generating enough pressure that is required to form aerolization. So again, HEPA filter, good mask seal, or LMA to reduce the aerolization. I'll end the high risk list with the sputum induction. There's no enough data about it, but it's regarded as high risk procedure. Starting with the medium or moderate risk procedure, nasopharyngeal swab is one of the moderate risk procedures as per CDC. There's no need for isolation room to conduct the procedure. A closed room with good PPE is enough. Okay. Throat exam is also a moderate risk procedure, and it's recommended currently to avoid any throat exam, and if clinically suspected, empirical antibiotic therapy can be initiated. Now, I haven't listed them, but it's worth mentioning that any parenteral access is regarded as a low-risk procedure. And then not to forget our colleagues in other departments, these are some of the high-risk procedure that is not commonly done in the ED. Bronchoscopy, dental procedures, and thoracostomy. I end my presentation here. For further information, these are the references I've used. So thank you all, and thanks for all fighters of COVID all over the world. Stay home. Sorry, not you. We need you. The world needs you. So you stay safe and stay strongly. Thank you for listening. Any questions?
I have a question. Tasneem, what are the recommendations for non-invasive ventilation? Because some people in the US are using CPAP to prevent intubations. Any comments?
Yeah, what I've read in the literature is it's only to be used if invasive or if high flow has failed. and it's recommended to be done in a negative pressure room and HEPA filter. Other than that, there's no enough data about it, or there's no clinical studies about it.
Thank you.
That sounds
Thank you,
great.
Dr.
Thank you, Dr. Tasneem, for an amazing lecture. I think that kind of gives us a visual on how risky certain procedures are, and then it segues into our next lecture with Dr. Abdullah Al-Hamoudi, who's going to be talking more in depth about airway management and resuscitation, which is more pertinent to our emergency colleagues over here. So without any further ado, I'd like to introduce Dr. Abdullah Al-Hamoudi for those of you who have not known him by far. He is a consultant emergency medicine physician at our, again, Zayed Military Hospital, and he's currently working at the Sheikh Shakhbout Medical City. He completed his residency training at the George Washington University in the US, and he has a special interest in wilderness medicine. He did a fellowship in extreme environmental medicine, also at George Washington University. He loves the outdoors, and he is currently working on a diploma in mountain medicine. So if all that wasn't enough, you know this guy likes some adrenaline. So he's going to be the perfect guy to talk about resuscitation, and I'll leave you in his capable hands. Dr. Abdullah.
Shukran, Anzal. Thank you very much. Can you all hear me perfectly? Can you hear me, Anzal?
Your voice is very smooth, yeah.
Nice, nice. Thank you, everyone. My name is Abdullah Al-Hamoudi. Assalamu alaikum. I'm practicing emergency physician at Zayed Military Hospital and currently just started practicing at Sheikh Shakhbout Medical Center. Inshallah, today we'll talk about resuscitation and airway management of COVID-19 patients for emergency medicine providers. This talk is a great segue to the talks that preceded, and they gave plenty of information. The way I laid the talk is by giving you a structure of what you normally do in resuscitating any unstable patient walking into your emergency department. There isn't much of a new information that you're gonna get out of this talk, but it's really a structure that will enforce what you know, but to practice it in a safer way. The objectives of the talk, we're going to review the basic principles of resuscitation, how to apply safe approach, especially when approaching airway management, and specific in regards to optimization of breathing and circulation. Before I move into the principles of resuscitation, I just want to point out that we should be suspecting everyone walking into the emergency department as COVID positive. We've seen a cardiac arrest who turn out to be COVID positive. Renal patients comes in with hyperkalemia and dysrhythmias, and they turn out to be COVID positive. Asthmatic infective exacerbations, COVID positive. Also the trauma patients who basically was at work, fell and have a fracture, turns out to be COVID positive. Few days ago, I had a patient with a suicidal attempt with corrosive ingestions, got admitted and turned out to be COVID positive. Whether that was on purpose to be infected with COVID as part of the suicide attempt, I have no idea. But everyone walks into the emergency department is COVID positive until proven otherwise. I think you already have an idea from what we've been practicing the last few days or the last few weeks. So moving to the principles of resuscitation. I just want to reemphasize that resuscitation, it's a systematic approach. It's something that we do in a systematic approach. We do it over and over and over again. It's consistent and involves a great and excellent team dynamics. Our resuscitation is not an individual skill. It's the skill of everyone in the team. If you have a great team dynamics, the result of resuscitation is gonna end up with great. These involve briefing. If we have, I know we have issues with getting EMS notifications and be prepared for receiving any critically ill patients to the ED. However, preparation, advanced preparation briefing is part of team dynamics. Effective communication is the most important one, especially when there is when there is donning of PPE and no one really can see anything apart from your eyes. It's really hard to communicate. Effective communication, it plays a crucial role when we are resuscitating patients on a full gear PPE. The purpose of resuscitations, we do primary surveys. We identify and intervene when it's appropriate, and we always do regular assessment. That's the principle. Those are the basics. How do we do it? We go with airway, breathing, circulation, disability, and exposure. That's a primary survey. It's different how fast we do it, but any critically ill patients, we should always be thinking that way. Whether we're doing a basic life support, an advanced cardiovascular life support, an ATLS or PALS, we always go with the same principles of approach, the most critical things, airway, breathing, circulation. But before that, and if you recall, before any course, you always are asked to assess the scene safety. Scene safety, it doesn't only mean there is a fallen rock that will hit you, or there is a road traffic accident with car moving that will end up crashing into you. It means put the simplest thing, putting gloves and approaching the patient. When it comes to COVID-19 resuscitation, we already had a great talk about how to keep yourself safe. Scene safety involves many things, including triage and the personal protective equipment. This cannot be more emphasized. We had great talks about it. Just be careful, comply with the hospital regulations, and protect yourself and your colleagues. The reason we emphasize on safety is because we want to be fit to work during this time, and we want to return home healthy without risking infection to our loved ones and without ending up transmitting infection in the hospital and outside. Safety, safety, safety is very, very important before moving to airway. When we see a patient coming in, crashing, a CPR in progress, if you don't have PPE on, you do not compress that chest. We're gonna go over that. But your incentive is to intervene. That should not be done without you being safe. I think I made that clear enough. So, in terms of COVID-19, is it any different? Do they have issues on airway, breathing, circulation? Do they have collective issues? For them to be really sick, the problem with COVID-19 patients, the vast majority is a breathing issue. It's something to do with their ability to oxygenate or ventilate, often with their ability to oxygenate. The breathing is the patient problem. And often for us to improve that, to intervene, we need to do something with the airway. So the airway is our issues, our problem. It's the thing that will give us and put it as the highest risk of getting that infection. So we should do all the precautions in order to minimize the infection while we're doing any airway maneuver or any aerosolizing generating procedures. So what we're going to talk about in terms of resus, we're going to discuss the resus of someone who already does not have a pulse, cardiac arrest patient, how to resuscitate them, and then how to resuscitate someone who's hemodynamically unstable and how to manage their ABCDE. We're just going to focus on the ABC, what things to do in the airway, what we do in the breathing, and one slide on the circulation component. So let's get started. In terms of cardiac arrest, the concept of protected code blue has been basically brought on by different recommendations, the American Heart Association, Resuscitation Council UK, and many others. Everyone describing the resuscitation and the ACLS, the BLS, and the pulse in a way that really doesn't change how we normally do. It's the same thing, it's the same layout, but we're protecting ourselves, we're taking extra precautions because we tend to forget that patients can put us at risk. It's not us only putting them at risk when we intervene. They can put us at risk. So those guidelines doesn't really change on how you're gonna assess much, but really of how you will be extra careful. So they come up with different points, and which are simple enough to understand. And before you intervene and you perform chest compressions, you will have a full PPE. Minimize people in the room. Only have in the ones you are in need of. If you're assessing an unstable patient, you generally need 3 individuals only. The physician taking care of the patient, the nurse helping you, and the RT, because you're often going to do some aerosolizing generating procedures in a safe environment, in the right setting. Minimize the people. If there's compressions and you need extra individuals, you're going to have an extra person in the room. Obviously, you do not listen or feel for breathing. You do not come close to their mouth if needed. If you have automated CPR device like the Lucas, use it. That minimizes manpower. That makes the resuscitation and the CPR much easier to run. If you are used to intubating individuals with the CPR in progress, you have to stop doing that. Stop CPR for airway attempt. Even if you're doing video laryngoscopy, do not insert an airway while you're performing CPR. In fact, you need to question the need of putting an advanced airway, a definitive airway, in a patient with an ongoing CPR. Use other things, minimize, have a proper seal, minimize basically the aerosolization. If you're using a BVM, use it with the filter and a tight seal. Often you will need 2-handed grips in order to ensure that tight seal. You want to reduce contamination, so you want to use the viral filter. That's what it's meant to be written here. So let's just review one of these recommendations. We're all familiar with the basic life support. It's the same thing. It's the same approach. You assess patient for responsiveness. You check their pulse if there's any signs of death. But before doing that, there is just emphasize, don the PPE. Limit the personnel, as we said earlier. When you're using a bag mask device, use it with filter and a tight seal. When you start in compressions, in terms of giving a breath, again, you should be prepared. We said resuscitation is about being systematic, being prepared, having good team dynamics. You should be prepared with a valve mask device that is attached to a filter and ensure a tight seal while you're giving breaths. If you do not have that, if that is not available, you can give continuous compressions with just a non-rebreather over their face for passive oxygenation. I know that doesn't serve them well, but being prepared will prevent you from going into that step. So cardiac arrest management is the same as it is. There is no change, but just keep in mind you're protecting yourself and you're protecting your staff. What about airway management? We're done with the cardiac arrest. What about airway management? Just to recap, in regard to airway management, what are the indications of intubation? Since COVID-19 became an outbreak, and we've seen more and more of those cases coming into our ED, intubation comes all the time on. And when it started, the first thing was avoid any aerosolizing generating procedures. Intubate early. All these recommendations were really with the fear of risking the healthcare providers from getting infected. But we have to revise what are the general indications of intubation that we do every day. When assessing a patient, we decide that patient needs to be intubated. based on things that we used to do all the time. Is the patient able to protect their airway? Is the patient in status epilepticus and has been vomiting? Is the patient comatose with a low GCS? I need to intubate them. What is this situation that make me decide I need to intubate? Is the patient able to protect their airway or not? If the answer is not, consider intubation. Is the patient in respiratory failure, that they're unable to oxygenate or ventilate? That could be a reason for intubation. But intubation should be a last resort. There is escalation of care. And that's often the case when it comes to the COVID-19 patient. But what we've been doing is rushing into intubation. So failure to protect airway, failure to oxygenate, and sometimes the anticipated clinical course. We've seen this a lot in polytrauma patients and severely burned patients. You know those patients gonna end up moved from a scan to scan, moving to the OR, being transported, probably impending airway compromise. They might need intubation. So the next thing is when we need to consider an intubation. Let's say I decided to intubate the patient. There is an indication for intubation. There is, as in COVID-19, there is failure to oxygenate or ventilate. And now I decide I need to intubate the patient. There is steps to do it. In the airway management, I'm not going to talk about how to perform an intubation. It's not about how to do the steps of rapid sequence intubation. It's just to point out the essential things that we need to consider when dealing with an airway of a COVID or suspected COVID-19 patients. There is different societies published guidelines on how to do this and in a safe manner and approach. They all kind of revolve on three things. They advise basically in minimizing aerosolization. And we had a great talk earlier of how to do that. It's focus on maximizing the first attempt success and limit contamination. Let's go over these quickly just to understand what things we should be considering. So in terms of minimizing aerosolization, have a well-sealed mask during ventilation. Use hand grips, 2 hand grips, in order to maximize that seal, and limit the use of a BVM. And if you're using it again, use a viral filter between the mask and the ambo bag. Also, when the tube is passed below the vocal cords, inflate the cuff before giving any positive pressure ventilation. Inflate it before giving any positive pressure ventilation. Try to resist that instinct. The moment the tube is in, I'm gonna back. No, inflate the cuff. And we do it also more of the time. We inflate the cuff and then we back. But to try to modify your technique, rather than passing the tube, inflating the cuff, and connecting the ambo bag, prepare in advance, have your respiratory therapist with you to be actually able to connect the ventilator straight into the tube, rather than just having to connect it to the ambo bag with bagging and then the ventilator. Try to connect it straight to the ventilator. In situations you need to bag and feel how the patient chest is, yeah, you can bag them, but try to minimize and limit the ventilator disconnect and to minimize the aerosolization. And if you're transporting the patient, if you're disconnecting the vent for some reason, if you're doing a lot of suctioning, if you're doing any procedure that will let you disconnect the ventilator, you may apply a clamp in order to also minimize the aerosolization. Simple enough, but things that we may not usually think about. In terms of minimizing aerosolization and also contamination, it's always better to discuss these things with your respiratory therapist in order to be on the same page. Think with them how to optimize this to the minimum. Next is maximizing the first attempt success. So how we do that? A video laryngoscopy will give you a great view. It depends on what you see, and it depends on your level of practice. But video will keep your body and keep your face away from the patient. It can also help by maximizing the first attempt of getting that tube in. Who does the intubation? Is it the resident? Is it the attending or the emergency physician? Who does it? Really leave it to the most experienced person in the room. That could be the most senior resident. That could be the physician himself. You know, when you are dealing with these situations, how confident you are in managing that airway. Your senior resident might be an excellent person and very confident and very skilled in using the video laryngoscopy. So why not? They can have a go with the confidence they are the most experienced individual. It's not the time to be teaching a first-year resident of how to perform an intubation in a critically ill patient during this time. You're risking their life, you're risking them getting infected or transmitting it to teams and others just for the sake of having an educational experience. It's the wrong time. It's the time where most experienced get to intubate. Also, use higher doses of paralytic. Earlier was mentioned in the previous lecture that the intubating procedure itself, it's higher risk when the patient is coughing, when there is gagging. That's where the aerosolization happens. You want to go higher in the paralytic. If you're using the succinylcholine with 1.5 mg per kg, go higher. Use 2 mg per kg. If you're using rocuronium, which we often do, and instead of going 1 mg per kg, go 1.5 mg per kg. Go with higher dosage. And remember, on those doses, you're going with the total body weight. The last thing is limiting contamination, and that's basically you want to apply the viral filters. You want to have the most risk is really the doffing procedure. When you taken off these the covers, the eye shield, the face shield, your gown, those are contaminated. You should be careful. And as I was said earlier in the comments, somebody suggested double gloving, and I totally agree with that. That's the appropriate thing to do, and that will minimize the risk of being infected while you're doffing. So again, airway management, intubation is the same. You just want to minimize aerosolization with the step we said, maximize the first attempt, and limit contamination. So this is a picture of our resus room in the SSMC. And on the right side, you see how the ambo bag connected with the viral filter and the mask. And if a patient needs nibs, the respiratory therapist can fashion, I didn't insert a picture of that, but they can fashion something with that, with limiting also the aerosolization of that. Anyway, in terms of resuscitation, and you want to do this airway management in a negative pressure room. This is a wide open resus area. Everybody's dressed perfectly fine, but it's a large resus area. And if you don't have a negative pressure room, what you could do is with a HEPA filter. The least you can do is having a closed room, a closed door. We do not have a glass closed door, but that's something that I think it should be essential. In every area you're intubating should be closed. If you do not have it and you decide that patient needs to be intubated, move them somewhere that is negative pressure with a HEPA filter, or somewhere that with a closed door. You perform your intubation and you go back to the area rather than aerosolizing the virus into the atmosphere of your working area. So breathing. And as we said, we finished cardiac arrest, we finished airway management, and now coming to breathing. The issue with the breathing and as an indication to intubate is failure to oxygenate or ventilate. So when a high-risk COVID-19 patients, high risk, those with cardiovascular disease, hypertension, ischemic heart disease, cardiomyopathy, diabetic, renal dialysis patients, immunocompromised, those high-risk patients, they often comes in with respiratory failure. That's what end up happening for them needing to be assessed in regard to their oxygenation and ventilation. Intubation, straight to intubation, is not the answer. There is escalation of cares. What about high flow nasal cannula? What about non-invasive positive pressure ventilation? The way I look at the breathing issue is dividing those high-risk patients into 3 categories. Dividing them into a high-risk patient who already have background healthy lungs. And so they could be dialysis patients with a healthy lung. They could be a cirrhotic patient, immunocompromised with healthy lungs. They do not have issues at baseline of their lungs. Or patients with obstructive lung disease, COPD or asthmatics, bronchiectasis, or the patients with pulmonary edema from heart failure. Dividing them into these categories, how would each of them present and how would they need assistance in terms of ventilation, oxygenation, ventilation? We'll leave the healthy lungs last. We'll leave the healthy lungs last. In terms of the other 2 patients, they have chronic lung disease, they have pulmonary edema. Rushing into intubation, we know it's not the right thing. You need to maximize. When you do an aerosolizing generating procedure, rather than saying no for non-invasive procedures, rather than saying no for high flow, do it in the right way, do it in the right setting, move them to a negative pressure or HEPA filter or closed door room and provide that treatment. Delay intubation if you can without causing adverse effects on that patient. They need, we know asthmatics and COPD patients, they need time sometimes with the system. They struggling with moving airway through the obstructive or very narrow airways. They need nebulizers, they need non-invasive. They fatigue when they ventilate. They need some positive pressure ventilation and CPAP or properly pressure support with the BiPAP. Allow them to have that. A heart failure patient, they come so short of breath and they asking you to be intubated from how terrible they look. But often you can actually reverse them quickly if they're hypertensive or normotensive with a good non-invasive positive pressure ventilation, with a good reduction of their preload and afterload, the usual thing we do. But rushing into intubation is not the answer. In terms of the healthy lung individual, those people, what I've seen and what is mostly seen is those people actually come in with progressively and gradually hypoxemic respiratory failure. When they come to the ED, they are hypoxic, but they're not, you're not making often the decision to intubate right now. That decision is often made in the ICU. That decision is made hours, if not days later. They slowly progress into that stage. So for us to encounter it, it's a low possibility, but with overcrowding and ICUs being full and then critically ill patients boarding in the EDs, we will have to make these decisions in the emergency department. But just to keep in mind, healthy lungs, those patients, they're often hypoxic. And hypoxia, assessing that, fixing that does not mean endotracheal tube. It means often for those patients, they require higher FiO2. That's what they need. And to decide on intubation, do not go with the number of how low that oxygen saturation is. Go with the clinical signs of hypoxia. I've seen a patient who comes in satting 87%. The patient tells me, I feel short of breath, but they're not tachypnic. They're probably just 20, 22, barely tachypnic. And the patient is not gasping for breath, not cyanotic, talking comfortably to me. The stats are bad, the number is bad. They've never had lung disease issue, but now sat in 87%. That patient progressively got hypoxic, but clinically, they do not manifest a hypoxic state that require intubation. So the decision, the point I'm trying to make, the decision to intubate is not based on a low saturation number. It's based on the clinical signs of hypoxia. Look at their mental status. Look at the degree of work of breathing. Because for you to intubate, you're trying to add, to help them, assist them. It's an assistant. So you assist them. They're not able to work hard enough to oxygenate themselves or to ventilate themselves. Now I intervene. But when they look comfortable, when they are mentating fine, do not be confused with the number. Make your judgment about respiratory failure based on clinical assessment, not on numbers. So those healthy individuals can benefit from higher FiO2. And you have to accept, based on the clinical signs of hypoxia, a lower oxygen saturation number. That's the algorithm we use on in SSMC, and the hypoxia of 88% is generally when the patients feel dyspneic and they feel uncomfortable. However, again, don't stick with the number. Patients can actually look much lower and clinically look comfortable. So don't stick with the number. What can you use before going to intubation? So I'm just going to go through the algorithm. From hypoxia, you always want to decide, is there an indication for intubation? You don't want to delay it when it's needed. But remember, you intubating because of a reason to protect their airway? Is it because they're failing to oxygenate and ventilate with maximizing the other methods of oxygen delivery or assistant ventilation, whether invasive or non-invasive? Or you doing it for anticipated clinical course? Decide. Then if there's no indication for intubation, then often some of them would tolerate nasal cannula, but we're talking about resuscitation. So you're gonna move away from nasal cannula. Now you kind of upgraded. You already resuscitated someone who did not tolerate nasal cannula. Options to use is high flow nasal cannula. We use this often for pediatric patients. They do great with severe bronchiolitis, and they probably amazingly. And this is an option to use for those patients. High flow nasal cannula can be applied. It's basically nasal cannula with a humidified, heated air that give you a large amount of flow, huge amount of flow. Some devices can give you 50 liters per minute. Others can give you up to 60 liters a minute, can give you high FiO2. And someone would argue those high flow nasal cannula can also give you a PEEP of how much PEEP can we get from high flow nasal cannula. It can be argued. Some would say every 10 liters per minute can give you 1 PEEP. It also depends on how open or how the patients are breathing, mouth closed, mouth open. It differs, but it can give you some PEEP. But the main thing is delivering high FiO2 to the patient. When you're giving it, you want to give a mask to the patient. You want to do the same thing. Have them in a negative pressure room and a HEPA filter, or at least in a single room with a closed door. You may use proning for those patients. You may escalate to non-invasive. We're going to go to the next figure to look at these things. Once you apply the high flow nasal cannula, readdress. You monitor the patient. There is a way to evaluate the response of the high flow nasal cannula. If the patient is not doing well while you're monitoring them, you question the need for intubation, you decide if they need to intubate. How to assess? This is an approach of how to assess, or this is a method of how to assess the high flow nasal cannula response. There is an index called the ROX index, which is basically a ratio of oxygen saturation as a measure by the pulse oximetry. For intubation is lower for patients with a ROX of equal or over 4.8. And if you see the picture here, I put numbers with kind of very low oxygen saturation, with a high FiO2 and with a high respiratory rate, but still the ROX index is high, higher than 4.88. So, but is this applicable to COVID? It's not. COVID just started. We do not have really any validated studies on how to assess this. Just keep in mind, it's not validated for COVID, but have something to guide your management. I would say the basic thing is basics. Clinical signs of hypoxia is the key. Are they comfortable? Are they alert? Are they cyanos? Clinical picture is the most important thing. This index may help you. So how to escalate the care from there? Let's say they're hypoxic, they're not tolerating nasal cannula. Now you escalate to high flow nasal cannula. Give it at least 10 minutes. See their clinical picture. Are they improving or not? The SAT number of 88, it's something to guide you, but it's not a strict number again. If the patient is improving, put them for 1 hour, then prone them. Proning and its effect on the COVID-19, again, there is no data, but it might help. If the patient is awake, the patient is tolerating nasal cannula, they can turn by themselves and prone. Why not? Let them recruit and oxygenate larger zones of their lungs. If the high nasal flow cannula in 10 minutes does not give you any clinical effect, does not improve SATs, prone the patient. If with the proning, they're improving, if with the proning, they're improving, again, assess their clinical picture. You may use the ROX index at 2, 4, and 6 hours as a guide. And if they're deteriorating, why not use a non-invasive ventilation? You can use the non-invasive ventilation and the proning at the same time. I do not have data for you in telling you how successful that is, but you will be the judge of that based on the clinical picture. Again, those patients escalate in a critical care settings rather than emergency department. High flow nasal cannula require a lot of oxygen, require actually hospital commitment in order to be able to provide that thing. If these fail, high nasal flow cannula, proning, and non-invasive ventilation, then you want to consider intubation. Once you start intubating the patient and started mechanical ventilation, consider protective lung strategy. Treat them as ARDS. Although we know now some of them do not behave like ARDS, but start with the protective lung strategies. There will be a talk later on by Dr. Al-Awadi, I believe, and who will cover all the aspects of mechanical ventilation management. So I hope by this stage, we have an approach to hypoxia. And those patients with healthy lungs, they're not coming in acute distress like the ones of obstructive lung disease or the pulmonary edema. The hypoxic, escalate their level of care. Go into high nasal flow cannula, then with a proning, non-invasive, with a proning, if possible, if you're comfortable, if the patient's comfortable, and then question the need of intubation every single time. That's what I have for breathing. So last slide, this is the last slide, so finishing literally now. I don't know why I have breathing and circulation. Should be circulation when a patient comes in a shock. The Surviving Sepsis campaign published guidelines of how to deal in shock and on COVID-19 patients. It didn't really change much. It doesn't give you if you're familiar with it, it doesn't give you a new approach, but I'm just laying it in front of you so you have an idea that your practice is the same. It's really the same. You're not making a lot of a difference in those patients. We target a MAB of around 65, 60, 65. You don't want to go higher, because going higher, it means you're targeting higher pressures, more fluids, and you want to avoid that. When it comes to fluid strategy, you want to be conservative in terms of fluid strategies. Often those patients are high-risk patients. Often they do not tolerate a 30 cc per kg of fluid. And to decide on the pressors, do not wait for the response to a 30 cc of fluid on their perfusion to decide to start pressor. No, start pressor early if needed. And start norepinephrine, always a good choice. Start it as a first line. But when you're starting to escalate norepinephrine, some say when you get to the 20s, but 20 is very high. If you reach 10, 12, add vasopressin as a second line agent to the norepi. And that's usually in ICU setting. But if the patient has some cardiac dysfunction, has some sort of cardiogenic shock, the second line agent could be dobutamine as per the sepsis guideline. If the patient have refractory shock with those pressors, give them a stress dose of steroids, hydrocortisone, 100 or 200 milligrams IV. What do you do? If they're confirmed or suspected COVID-19, treat them as sepsis. Give them enteric empiric antibiotics. Treat them as sepsis and wait for the blood cultures. The blood cultures are fine and you're convinced this is not a bacterial infection, stop the antibiotics. But manage them as sepsis and do the same thing you do for the rest. Thank you very much. And I finished my presentation. Thank you very much. Any questions? Sorry, I cannot hear anything.
Thank you very much, Dr. Abdullah. Like he said, any questions either in the in-chat window or by disabling your mute on the mic? Dr. Abdullah has given, I think, a more comprehensive review of anything and everything that you should be considering when you're going towards a recess nowadays, which is with any kind of a COVID suspected patient. Does anyone want to have any questions for Dr. Abdullah?
I have a couple of comments. Sorry, Abdullah. Assalamu alaikum.
Wa alaikum salam. Hi, Umar.
A couple of, so first question, if you don't have, which is going to happen soon enough, HEPA filters or negative pressure rooms, and you have more than what's required in terms of intubation patients, do you have access to, I mean, should we be wearing PAPRs, which is what they're using in New York and the UK, and you know, they have a COVID hot zone where everybody's wearing PAPRs throughout the shift. Is that something to think about?
Yes, so totally.
Just as complete, you know, complete hazmat for the whole shift.
Yeah, exactly. Because what you now, when your ED, that's a very good question, Omar. Thank you. When your ED is already packed with individuals, it's just full of individuals who suspected of COVID, and we said everyone walking in is a suspect of COVID. When the whole ED is become a single room with aerosolizing procedures, with patients coughing, patient getting non-invasive procedures, it is hard to say no, do not put a full gear, because it's just unpreventable. You will get infected if you do not protect yourself. So yes, when you cannot contain it in a closed door in a negative pressure room with a HEPA filter, and yeah, your situation is different. Now you have to, and you're performing aerosolizing procedures for those individuals, your risk is higher. At that situation, what you may do is basically anyone in certain areas, you just want to segregate them. If you're doing any intubation, have a room to intubate, move them to that room, perform your aerosolizing procedures, and get them out on an area where you think it's well ventilated or negative pressure, or where it's less risk. If you're manipulating a non-invasive ventilation, move them to that room, fix things, and get them back. But to be honest, these are hard. The tubes get moved all the time. They get dislodged. Ventilators get alarmed all the time. Is it a guarantee that nobody gonna aerosolize? It's not. So having a full gear, I think it's the right thing to do.
And so just one, I have a comment actually. So the comment is that I actually agree with what you're saying in terms of being emergency physicians. We should be treating patients, not numbers. And this has come out of experience from New York specifically, where a lot of my colleagues are working in emergency medicine, and they're tolerating a lot lower percentage of oxygen saturations as long as the patient's not dyspneic. So if their still respiratory rate is 20 and they're saturating at 90 and they're not diaphoretic, they are so the threshold for sending people home is also sort of increased in terms of capacity issues and so on. So I think that's quite appropriate, and I think this is something which we it's brought a change in our mindset as to how we manage patients. And again, it's to reiterate that we should essentially treat patients, not numbers.
Totally agree. Thank you for the comment, Amar.
I believe Dr. Naeem is asking a question, Dr. Abdullah, about Perspex Pulse.
Can you take the sharing from the screen? I'm using Mac, and for some reason, I'm not able to actually see the chat area. Let me see, actually.
You should have it now, yeah.
Let me see. Yes, I see that. That's a great question. Yeah, so the Perpex boxes, this is basically the glass boxes that cover the patient head and trunk while we are intubating. There is some, I think, that comes with like complete box. Others come with I'm explaining for those who do not know about it, and things that come actually with a better angle when you viewing the patients, that you insert your hands through these openings and you intubate. We do not have these. We do not have these. We do not use it. These can be improvised with basically having a clear covering over the patient when you're attempting to intubate. Obviously, intubating using a video laryngoscopy, where you can actually comfortably intubate without having to get close to the patient. So improvise with the clear covers over the patient head while intubating. That could be an option. Having these devices are excellent. They're easier to clean. They've been tried, and the people just use it often in the US where it's been used. I'm trying to go over kind of different questions. Yeah, Farron asked, yes, initially the non-invasive ventilation was a no-no for COVID cases. However, because it was a no-no, patients were getting intubated way too early, and they stay longer on the mechanical ventilations. But the reason, again, are we intubating them because of the safety issue, or are we intubating them because of their clinical status? When it was a no-no, it was for a safety issue to minimize the aerosolization. But again, this can be done in a better way, a better seal, in a closed room, in a single room, in a HEPA filter. I know these sometimes unrealistic, having every single patient in such room. But you can combine patients in a negative pressure room if they all have COVID positive. What I was going to say, any more questions?
I think this topic is extremely important, and I guess it's more pertinent to us in the emergency department. So I think the discussion is probably going to go on for a while. I just wanted to mention to everyone else who's here, at this point, you guys are free to take a break for the next hour. We're going to be reconvening and rejoining this session at 1 p.m. I'll be ending the call in about 5 minutes. Post Dr. Abdullah's lecture, there are a few links that I've posted up that might supplement your academic learning, especially for the residents, especially when it comes to the concept of protected code blue. Now, different modalities have been suggested about how to protect yourself through code blue, but at the end of the day, the unfortunate hard truth is that it's going to be subjective, case by case, and based on your best clinical or expert opinion. Because at the end of the day, even the boxes have limitations, even the different kinds of rooms and filters have limitations. So you have to use what you have in the best way you can. And I think that's what most of us are going to be learning and contributing to our separate departments in the coming, hopefully, days and weeks with the coronavirus. Thank you everyone for joining, and thank you again, Dr. Abdullah.
I just want to add, Anzal, I just got a text from our amazing resident, Isra. We do have the glass actually in the SSMC ICU. She sent me a picture of that. So we do have in the ICU, so it's great. And I think it's appropriate location to have it in the ICU, but probably we need to utilize in the AD for those who are crashing too. Remember when I said the 3 categories of patient, the healthy lung ones, who slowly deteriorate and usually intubate in the ICU. For the other 2 who we're intubating in the ED if needed, I think probably good to have it in the ED. But so the answer is to Dr. Naeem Al-Tusi, it is available, yeah. Thank you.
I think that's fair. It's a really good option to have it. It's nice to know that it's present in SSMC. However, some people have subjectively reported that, you know, it's a lot more difficult for them to maneuver. So if it works for you, great. If it doesn't work for you, go with what you think protects you best. And just a reminder, we have 3 more lectures after the break. Dr. Hussein Al-Awadi, Dr. Abdurrahim Al-Baksh, and Dr. Akil Salim. They're going to be talking about ventilation strategies, epidemiology, immunology of the virus, and treatment modalities. So thank you everyone for joining. I hope it's been a productive day for everyone. I will be ending the call in a while, and the same call with the same code will be open for you guys to join for the second part of the day. Feel free to have lunch and breakfast if you're working from home. Thank you very much.
That's better now. So by the end of this lecture, we'll have an overview of the inception, spread, and relation of this current disease to prior pandemics. We'll also go through a little bit on the virus cycle, the receptor binding, and the physiology of this virus and the disease. And we'll also see how existing medications and drugs interact with the SARS-CoV-2 virus, and in particular we'll go over a little bit. We'll go over the renin-angiotensin aldosterone conundrum that's prevailing, and it's in a hot discussion these days. Just like everyone else, I just want to mention that the information about this disease is changing, and new information is coming up on a daily basis. So perhaps things might not remain the same as presented in this presentation in the future. So on 31st of December 2019, the World Health Organization was informed of 44 cases of pneumonia, which were of unknown microbial etiology in the Wuhan city, Hubei province in China. And most of these patients in the outbreak were linked to the Huanan South China seafood market, which is a large market with a wide variety of animals. On 24th of January, this was officially published in the New England Journal of Medicine. And at that time, the virus was labeled as the 2019 novel coronavirus, and the disease was called the novel coronavirus infected pneumonia. This is available on New England Journal of Medicine, and you can access this on the link below. And then since then, the outbreak escalated rapidly. On 30th of January, the World Health Organization declared this outbreak to be a public health emergency of international concern. And finally, on the 11th of March, this outbreak was declared to be a pandemic. Now, this is an important event because once you declare the outbreak to be a pandemic, there are a number of measures that that governments can take and health organizations worldwide can endorse, which can help to prevent the spread of this disease, such as quarantining, isolation, restricted public movement. Yes.
I'm sorry to just cut you in. Are you sure you have pause sharing, resume sharing done? Because we can only see the title screen.
Oh, I'm so sorry. I think, can you now see it?
We can see it now.
Okay, I'm sorry about that. So just to go through, this was my previous slide, and and this is the current slide. On 11th of February 2020, WHO labeled this disease as the labeled the virus as the SARS-CoV-2, the severe acute respiratory syndrome coronavirus 2. This is to differentiate from the severe acute respiratory syndrome coronavirus 1, which was again an epidemic in the early 2000s, again from China. And the disease was called the SARS-CoV-2 associated coronavirus disease, COVID-19. Now we have information about the earliest reported cases of the coronavirus, and it started and it was reported in the New England Journal of Medicine, where they reported 3 adult patients from the Wuhan province in China who presented with severe pneumonia requiring admission. And the first was a 49-year-old female who was a wholesale seafood retailer, and she presented with fevers of 37 to 38 centigrade, cough and chest discomfort. 4 days later, the fever subsided, but her cough and chest discomfort worsened, and her CT scan of the chest revealed bilateral pneumonia. This patient fortunately improved and was discharged 3 weeks later. The second patient in their case report was a 61-year-old male who was a frequent visitor to the seafood market, and he presented with fevers, cough, which progressed to respiratory distress in 7 days. This patient was mechanically ventilated and died 3 weeks later. More information on this patient arrived in subsequent articles. This patient was actually on ECMO for 2 weeks and subsequently died of multi-organ dysfunction. The third patient was a 39 years old and also survived. And this is the article where these cases were mentioned, and also the first description of the coronavirus was mentioned. I just want to add that all of the resources relating to COVID-19 are available for free on the New England Journal of Medicine website. So you don't need a subscription. You can get these articles if you get access to the website. This is the chest X-ray progression of the patient in that case report, which passed away, one of the earliest cases. And you can see the opacities are predominantly peripheral. They're sparing the central zones. They're predominantly peripheral, and they're mostly basal. They're sparing the upper lobes generally. And in the X-ray B over here, you can see that they have significantly worsened. Now, the majority, the spread of this virus, regarding the spread of this virus, the majority of the patients were associated with a wet market where there are a number of different types of animals. And this suggested that this virus is zoonotic in origin. Now, studies at present have suggested that the virus may be a derivative from a recombination between a bat coronavirus. Specifically, they're implicating the horseshoe bat and an origin unknown coronavirus. However, nothing is confirmed at the moment. Also, they're not sure if the virus transmitted directly from the bats to the human beings or if there was an intermediate host involved. But at present, they're suggesting that pangolins could possibly be an intermediate host, as they have as they are a natural reservoir of a large number of coronaviruses, which are quite similar to the SARS-CoV-2. This is what a pangolin looks like. It's basically an anteater. and it has these scales on its surface. Of note, the scales on the body of the pangolin have been used in traditional Chinese medicine, as well as in making samurai shields. Transmission dynamics, when we talk about epidemiology, person-to-person spread has been confirmed in community and healthcare settings, and local transmission is occurring in many countries around the world. Now, one thing that you may have heard about is local transmission and community transmission. The difference between the difference between local and community transmission is that local transmission, you call a disease to be local transmission when you can accurately identify the chain of infection, when you can find when you have a case of COVID-19 and the patient tells you, I think I was in contact with someone who was also ill, or perhaps that patient came back from an area where the disease is widely prevalent. Whereas community transmission refers to the spread of a disease where you cannot identify where this patient got the disease from. It suggests that there perhaps is a pool of subclinical undiagnosed cases in the community, and the disease is widespread. Now, out of when the cases started coming out from China, 55% of the cases before 1st of January were linked to the Huanan South China seafood market. Subsequent to that, only 8.6% of the cases have been linked to the market. So this suggests that the disease has spread globally, as we know at the moment. This also suggests that the person-to-person spread is occurring, and it's amongst close contact since the middle of December 2019. And healthcare workers are an important source of infection, as spreading this infection as well. We know that the infection transmits through respiratory droplets, and it transmits through contact with fomites. At present, airborne transmission has not been reported, but we have to take cautions in aerosol generating procedures. There's also the question whether you classify aerosols as respiratory droplets, or whether you strictly classify them as airborne transmission. Pre-symptomatic transmission refers to the fact that people can be contagious during the incubation period. The incubation period of a disease is the time when the patient has been exposed to the virus, and up until the time they have onset of symptoms. We know now widely that for coronavirus, this is around 14 days. Now, in China, pre-symptomatic transmission has been reported in 12.6% of the cases. In Singapore, they identified 6.4% of patients among 7 clusters in which a pre-symptomatic transmission was likely to have occurred 1 to 3 days before symptom onset. So perhaps that's when the patients are shedding the virus the most. But we know that viral shedding is maximum when the patient is symptomatic. The incubation period of the disease is estimated to be between 1 to 14 days, with a median of 7 days. And 97.5% of the patient will develop their symptoms within 11.5 days of the infection. Now, asymptomatic transmission describes laboratory confirmed cases who do not have symptoms. As mentioned earlier, patients are the disease is most transmissible when the people are most symptomatic around the time of symptom onset, as we saw in that study where 1 to 3 days before the onset of symptoms, people were transmitting the disease. The estimates of asymptomatic cases range widely. The WHO estimate is at present around 25%, but studies have reported asymptomatic cases could range anywhere from 4% up to 75 to 80%. Super spreaders are individuals who probably may be asymptomatic or pre-symptomatic, and they pass on infection to a large number of contacts. Again, we are seeing news reports of super spreading events where people coming in contact with a single individual, a large number of people have acquired the disease. This super spreading events were also noted in the SARS epidemic in the early 2000s. Another thing that we need to know about is the reproductive number of the disease when we're talking about epidemiology. The reproductive number refers to the number of people who acquire the infection from an infected person. So for SARS-CoV-2, it's estimated at around 2.2 to 3.3. So one infected person may transmit the disease to about 2 to 3 different people, according to various estimates. This table here shows you the reproductive number of the SARS-CoV-2. We can see, for example, here measles has a reproductive number of about 12 to 18, so it's much more transmissible than SARS-CoV-2. That doesn't mean we should take SARS-CoV-2 lightly. We should take we should take all of the necessary precautions that are advised at the moment, given that there is no cure for the disease. The threshold here refers to the herd immunity threshold, which is the number of people, healthy individuals in the population, who have acquired the infection and have recovered. Meaning that the remaining population don't, meaning that they confer a protective effect on the entire population. For measles, it's about 83 to 94% of the people need to be infected and recovered for the population to achieve herd immunity. Now, for SARS-CoV-2, actually, at the moment, there is no proven or no concept of herd immunity, because we're not sure whether the antibodies to the in a COVID-19 infection that are present after the patient recovers, if they're protective or not. And secondly, there's no vaccine at the moment for COVID-19, so the concept of herd immunity doesn't apply to SARS-CoV-2 at the moment. This picture here shows us the relation of the SARS-CoV-2 to prior pandemics. As you can see that China has experienced a lot of viral epidemics, starting from 1957 when they had the Asian flu, the H5N1 bird flu pandemic between 1997 to 2003 in Hong Kong, the SARS epidemic in 2003, and currently the SARS-CoV-2 virus COVID-19 pandemic. There are a number of similarities between SARS-CoV-1 and SARS-CoV-2. They both share about 85% of their viral genome. They're very identical. And both of them can be cultured in human epithelial cells. SARS-CoV-2 is grows more easily in human epithelial cells compared to SARS-CoV-1. Now, talking about the viral structure and cell cycle, the SARS-CoV-2 belongs to the Coronaviridae family of viruses, and it's actually a positive single-stranded mRNA virus. Up until prior to the origin of this virus, there were 6 known species which were associated with human pathology. 4 of these, the ones 229E, OC43, NL63, and the HKU1, these basically cause common cold, and in neonates they may cause a bit of diarrhea. The other 2 viruses are the SARS-CoV-1, which was associated with the severe acute respiratory syndrome epidemic, and the Middle East respiratory syndrome coronavirus. Outbreaks of coronaviruses, excluding the COVID-19, are common, and they can account for up to a third cases of upper respiratory tract infection, common cold, in adults and infants. So SARS-CoV-2 is the 7th coronavirus which is known to cause human pathology. Now, Coronaviridae are widely prevalent in animals. You can see there's a large list of this coronaviruses, and most of them belong to most of the coronaviruses which cause pathology in human beings are in the beta coronavirus family. And so is the SARS-CoV-2, which is a beta coronavirus as well, just like the SARS-CoV-1 and the Middle East respiratory syndrome related coronavirus. I have a video here which describes the structure of the SARS-CoV-2. This is from the American College of Physicians website. Unfortunately, I've been told that the audio doesn't work in these on this webcast. So I'll just talk through it. So this is the coronavirus. It has an outer envelope and the inner genetic material. The genetic material, as mentioned earlier, was a positive sense RNA, and these structures around the genetic material are the nucleocapsid protein. They sort of package the genetic material into the viral envelope. And this is the RNA, which is the genetic material of the virus. Now, the viral structure itself has a number of important proteins which are crucial to its infectivity in the human beings. And as the video comes up, I'll talk through them. So it has the spike protein, it has the E protein, and it has the hemagglutinin. The E protein, of course, is the envelope protein. This is the spike protein, the S protein, and it's critical in the virus infecting its host cell and entering the cell, and subsequently causing the disease. So this diagram here shows the stages of the SARS-CoV-2 infecting a cell, and it's important in that the current at present, as we don't have any treatment modalities, knowledge of the virus receptors and how it's infecting the human cells is helping us look for existing therapies which attack these pathways. So at first you can see these projections on the surface of the cell. These are the S proteins, and this over here, this is the cellular receptor. This is the ACE2 protein. So the viral S protein binds to the ACE2 receptor, and it continues binding so until it's enveloped by the cell membrane itself. This is called this results in the endosome formation. Following this, the endosome is internalized, and a protease called the TMPRSS2 protease releases the S protein from the ACE2. The virus still has to exit the endosome, and it does it by a number of procedures, one of which is acidification. So as these endosomes are identified by the lysosomes, and they begin attacking them and dropping the pH, the virus is dropping the pH of the endosome. The virus is activated to form holes in the endosome and exit. Now, this process of acidification is what is being targeted at present by hydroxychloroquine and chloroquine. The TMPRSS2 protease activity is being targeted by camusat mesylate, which is a medication which is used in pancreatitis, and in Japan it has been approved for use in coronavirus. This is a reconstruction of the molecular structure of the spike protein over here, which is a structure on top, which is interacting with the ACE2 enzyme which is expressed on the surface of the cell. ACE2 enzyme is expressed significantly in the lungs, specifically in the type 2 pneumocytes, as well as in the heart cells. This is the so this is a picture which is showing which was published in the New England Journal of Medicine, which is showing the virus infecting the infecting a cell via the ACE2 enzyme receptor, ACE2 enzyme, and the effects of this on the and how the renin-angiotensin-aldosterone system interacts. Now, they were concerned regarding the use of ACE inhibitors and the angiotensin receptor blockers in patients who are using these medications who are infected with coronavirus, given that the SARS-CoV-2 is using the ACE2 receptor. And we'll look into this a little bit in detail. So this is your renin-angiotensin system. You have the angiotensin, which is converted to angiotensin 1 by renin, and the angiotensin 1 is subsequently converted by the ACE1 to angiotensin 2. Now, you have to keep in mind that the ACE inhibitors block ACE1 and not ACE2. So the ACE1 converts angiotensin 1 to angiotensin 2, and the angiotensin 2 subsequently acts via the AT1 angiotensin 1 receptor. So that's summarized over here. So you have the angiotensin 2 acting via the angiotensin 1 receptor, and what this results and this is implicated in acute lung injury, adverse myocardial remodeling, vasoconstriction, vascular permeability, and other deleterious effects. And for this reason, as we all know, we use ACE inhibitors and ARBs in patients with heart failure. Now, you can inhibit this pathway by ACE inhibition, by preventing the conversion of angiotensin 1 to angiotensin 2. You can prevent this by using angiotensin 1 receptor blockers, the ARBs, such as losartan, valsartan, which act at the AT1 receptor. You can this is the ACE1 mediated pathway is counteracted by the ACE2 enzyme. Now, the ACE2 enzyme converts angiotensin 2 to angiotensin 1,7. And studies have shown that by acting through the MAS1 receptor, the mitochondrial activity subunit 1 receptor, the ACE2 has a protective effect in lung injury. It antagonizes the angiotensin 2 activity. It has vasodilatory effect on the vascular bed, reducing pulmonary pressures, and it is even myocardial protective. The concerns are that ACE2 is upregulated by inhibition of ACE1. And given that it is an entry receptor for SARS-CoV-2, there's a controversy whether ACE inhibitors and ARBs could be provoking, could be predisposing people who are on ACE inhibitors to COVID-19. There are the other side to this is upregulation of ACE2 could possibly be protective in the ARDS and the lung injury that is the lung injury and the ARDS that is seen in the severely ill COVID patients. So it's not clear at the moment, but there are trials underway using losartan, specifically in the University of Mississippi, and also using recombinant ACE2 to see if they have any protective effects or not. This is my last slide. Now, again, this is showing how the knowledge of this slide is showing how the knowledge of the viral cell cycle helps us in looking for existing drugs which can possibly help in the treatment of COVID-19. Chloroquine, you can see it mentions here, it blocks endosomal acidification, also blocks viral entry by inhibiting glycosylation of host receptors. Hydroxychloroquine has a similar effect. Kaletra works by inhibiting the 3CL protease. You have the umifenovir, which is an ACE protein, S protein ACE2 membrane fusion inhibitor. And then you have the viral replication inhibitors, the RNA polymerase inhibitors, the remdesivir and the favipiravir, the Afghan, which is available over here. That is my presentation. So in conclusion, the epidemiology of the disease helps in taking adequate preventative measures, particularly when no effective treatment is available and supportive resources are limited. The knowledge of viral cell cycle is fundamental in designing therapies aimed at eradicating the virus until an effective vaccine and sufficient herd immunity has been established. And a number of trials are currently underway investigating established known drugs as potential treatment with the knowledge of the aforementioned in hand. These are my references. As I mentioned earlier, the New England Journal of Medicine have made their COVID-19 resources free for access. The other thing I'd like to mention is, given the huge amount of information that is being circulated on social media regarding coronavirus and COVID-19, the Oxford University have their Center of Evidence-Based Medicine, which is beautifully summarizing all of the existing, which is looking over all of the existing data and summarizing it beautifully. So if you do come across any information you're not sure of, check out their website. That's the end of my presentation, and thank you very much.
Thank you very much, Dr. Abdurrahim. Do we have any questions for, I can start with this one in the in-chat window for you. It's more of a colloquial question for you. Dr. Naeem Tusi is asking if you have any comments on the name of the virus, COVID-19. which is slightly more different than usual virus names, as it seems designed for internet or social media use in the hashtag era.
That is true, but what I'd like to mention here is that the virus has been officially labeled as the SARS-CoV-2. Coronavirus is something which is which is a family, a broad term, but the name of the virus specifically is the SARS-CoV-2 SARS-CoV-2. But yeah, I think coronavirus and COVID-19 virus would probably be more social media friendly, I would say.
No, sorry, I meant the disease, of course. It's a bit of a strange name for a disease, as it doesn't quite fit with most diseases names of diseases that we know. It's just out of interest, really. I've been curious about it. I just wondered if you felt it was a bit of a strange disease name or not.
Well, I find a SARS-CoV-2 to be a bit more medical than COVID-19 virus. One of the things that they have found is that the SARS-CoV-2 is very closely related to SARS-CoV-1. I guess perhaps that's the reason why they have labeled it as such. But I'm not sure why the virus is named as such. Regarding the coronavirus, the name of the disease itself, coronavirus disease 2019, I do agree that's a bit generic. But I think as more and more information comes in hand, as we keep finding things which are more particular to the disease, perhaps the name may change to something different. But honestly, I don't have much information on this, to be fair. So I can see this question, any data on about those who are already on ACE inhibitors for hypertension and CHF, how do they do? So at the moment, there is no information available on these patients. There are some retrospective analysis, and retrospective analysis have been conducted on from data that has come from China. They did notice that there was increased mortality in patients who were hypertensive, who had existing heart disease, who had existing cardiac comorbidities, congestive cardiac failure. But it's not clear whether the presence of hypertension is whether the increased mortality in hypertensive patients was linked to the use of ACE inhibitor, or was it just that they were simply more ill than other people, other patients. Again, this is all retrospective data. At present, trials are being conducted. What I know of is the University of Mississippi is conducting a trial with losartan. The results of this will probably take some time, but it is designed to be it is looking into how the use of losartan in patients with COVID-19. So yeah, let's see when the results of the study come out, if there is any increased mortality in those using ACE inhibitors or ARBs or not. Okay, so as the admin is slightly busy, I'd just like to read out this comment from Ruth Lidgo, who is an R2 resident in our hospital, and she's mentioned here that the WHO had a committee that met to decide on the name with multiple specific requirements, and it had to be easy to pronounce in any language, not to make any reference to any race, ethnicity, location, or animal. COVID-19 is what they came with. So I think that's a good explanation. Thank you, Ruth.
All right, so if there's no further questions, we will move to our next talk. Thank you, Abdurrahim, for the very nice breakdown of the epidemiology and immunology, and especially with regards to the ACE. I think that's one thing that everyone was kind of wondering, whether or not we can still continue our ACE inhibitors in these patients. So I'd like to introduce our final speaker for the day, Dr. Akil Salim. He is an infectious disease and medicine consultant. He's from the Tawam Hospital in affiliation with the Johns Hopkins Medicine in Al Ain. And for those of you who have ever been there, you would know he is also the program director since 2017 for the Internal Medicine Residency program. He completed his IM residency in the University of Pittsburgh in the US, has completed a fellowship in infectious disease from the University of West Virginia, and has a diploma with the American Board of Infectious Diseases and Medicine. And with that being said, I think he is the perfect person to transition into our final discussion for treatment modalities in COVID-19 patients. Welcome, Dr. Akhil.
Yeah, thank you, Anzal. It's my opportunity to talk on few of the things that we need to understand a little bit more in detail. I hope everybody can hear me, probably.
Everyone can
So good
hear you,
afternoon.
and we have a special message from Dr. Hussain saying that he always learns from you and he wants to send his regards. I think
Yeah, likewise. It's likewise with Dr. Hussain. Same, I learned with from him and he learns from me. So it's likewise. So good afternoon. It's been a long day. I'll try to will not try to be redundant, but I think some slides might be redundant since it's a vast topic, and we are newly introduced to this topic as a new modality for us. But I think most of us have come through, or most of us know about this kind of knowledge about what to do and how to do and what things to be protected. So without any delay, I will give you my objectives. I will describe a brief history. I will go into morbidity and mortality. Will describe some signs and symptoms. We'll discuss a little bit about personal protective equipments, diagnostics, treatment, and new modalities and different organ system dysfunction and new possible treatments. So brief history about corona. Corona is a beta coronavirus that infects frequently animals. There are 7 species known to infect humans. We had SARS-CoV, MERS-CoV, MERS-CoV-2, which can cause severe disease, which we currently are facing. There are other types of coronavirus, which are called HLK1, NL63, OC43, 229E, which are associated with milder symptoms. I don't know, many of you might have seen the respiratory panel, which is a PCR panel in which if you see microscopically, there is one stated coronavirus, that is probably one of these HLK, NL, and nobody has tried to put emphasis on that until this deadly corona came in. And we got a call from one of the patients that, Doc, I'm corona positive. So we saw all the COVID-19 and everything which were negative. Then he sent us his respiratory panel, and his respiratory panel PCR in that corona was positive. So that corona has mild symptoms, or it is not associated with that morbidity and mortality, and potentially we should not treat that one. So that was an interesting story about that corona which has mild symptoms. So going back in 2002 and 2003, in November, we had SARS, and quite less people were infected, but affected like 8,098 worldwide. And they were sick, and only 774 died. I should not say only, but relatively comparing to our new virus, this is really less mortality. MERS-CoV, we found it by November 2019. 2,484 cases reported, and 858 deaths were there. And still we see sporadic cases still occurring around us. I think Dr. Wadi might have seen off and on in ICU, these cases. So as of April 14, I was just browsing last night, 2020 until last night, the cases we have, it's crossing around 200,000, and the deaths are 195,000, and recovered are quite big number also. So the problem is the cases means the patients who are getting infected, the infectivity of this virus is huge, and that's why the whole I think the things came into play, not to have wear masks, not to have we need to have lockdowns and minimal traffic and spraying and masks and everything going on, sanitizers. So that's why the cases are more, since the infectivity is more. If the infectivity is more, the mortality will be more, and the mortality will be more. But we have to see that equal number or a little bit less number are recovered also from COVID-19. Then if you go to total daily new confirmed cases, if you see the total number of deaths as per April 14, 2020, as of yesterday, and they're still going up. It went up from 100,000. The recent one is 114,000. It was less than 100,000 2-3 days ago. But the thing is, I think we are screening people. If we screen people, we will find more people. So I think it's a phenomena which is, you screen more, you get more. You get more, then even if the death is from some other cause, you will probably think that it's a COVID-related death. I will describe that what other organ systems COVID can infect or can affect. So you will be surprised to see that how contaminated hospitals are. If you see the slide, that everything you touch is contaminated. In ICU, there is a contamination rate of 31.9%. Obstructed isolation wards, 28%. Isolation ward in COVID, it's 20%. The scanners, printers, 20%, keyboards, 17%, our locked doors, 16%, telephone, 12%, medical equipment, 13%. So what should we do? Our sanitizers are also infected, 20%. So everything is there. So as I think one of the speaker I was listening a couple of days ago, he was saying that wearing a mask probably is going to protect you from active infection, but it might or might not protect you from the person who is coughing on your face that might have COVID. So, and as you have seen, all these how contaminated our hospitals are, we are trying to decontaminate them, but it's practically impossible. This is taken from Sloan Kettering Hospital. So just coming back to the case definition of suspected COVID case. So I'm just quoting the Health Authority Abu Dhabi, Ministry of Health Dubai, and Dubai Health Authority, and all these. So how they compiled all these case definitions, I'm going to go in that way. So what is the case definition? Patient present with upper or lower respiratory symptoms with or without fever and any of the following, or all severe acute respiratory infections, which is called SARI, S-A-R-I, admissions regardless of exposure history, that would go down, and history of international travel during last 14 days prior to symptoms, close contact with individual known as confirmed case of COVID within 14 days, or residing or from a community setting, our COVID cases were detected, including healthcare settings. And ill cases, fever and cough without history of travel or non-exposure, all these patients are high risk. And according to the guideline, we need to admit to risk assessment. We have occupational health. They will go to occupational health and they will do their risk assessment. The low risk patients would be sent home. They might be sent back to their work. Moderate and severe risk patients, they would be quarantined. They would be asked to be in isolation for 14 days. And their 2 samples are negative, including day 1, day 2, and 12 they are negative, then they would come back to work. So possibility of COVID-19 infections we can collect from nasopharyngeal and oropharyngeal swabs or sputum or BAL samples. Samples for patients from lower respiratory tract symptoms, if possible, like our intubated patients. Advise home quarantine for suspected cases. As we said, send samples to reference laboratory. Now we are doing in Tawam. Before we used to send it to SKMC. And if possible, admit for isolation according to the metrics. Then there is a definition which is, I think everybody is asking around, SARI. What is the SARI? SARI is an acute respiratory tract infection with history of fever or measured fever of more than 38 degrees Celsius, cough with the onset of last 10 days and requires hospitalization. And this flow chart may change as further information emerges. So currently we are having meeting for COVID every day in our hospital. We are in collaboration with Alain Hospital, and then there are a couple of other small hospitals that those are accommodating our COVID patients. So we are in contact with those also. So we divide the population into asymptomatic, mild, moderate, and severe. As you can see, I would not elaborate further. So the moderate ones are have oxygen saturation low and they have pneumonia. The mild cases don't have pneumonia and oxygen saturation is fine. The severe one have a severe pneumonia and oxygen saturation is very low, and they might be needing intubation, and their respiratory rate is more than 40. Then we come to the risk metrics for COVID to support physicians to make decisions, admission priority. Actually, this is a very difficult thing since we are flooding with the COVID patients. So it is very hard to decide that whether who to admit and who not to admit. And there is a center, quarantine center. There are a couple of hotels which are assigned as a quarantine. So hospital patients, if their patient is asymptomatic, they can qualify for hospital admission or institution with medical care, like nurse would be there, doctor would be there, but there would not be like ECG, like a monitor, or they would be done ECG if necessary. And if there is no risk, we are thinking on the grounds, but still we are not there. We'll probably sending them back to home with a strict isolation if they agree with us. Mild would warrant hospital admission and institution admission with medical care. Moderate, of course, will go to assigned medical hospital. And severe and critical, they might end up in ICU. So definition of high risk as people aged 65 years and older, and who patients who live in nursing home or long-term care facility, because these people are at high risk already from the beginning. Other high risk factor include people who have chronic lung disease, that have bronchiectasis, or they have severe asthma, COPD, and other people, the people who have serious heart disease, the people who are immunocompromised, including cancer treatment, people who are people of any age with severe morbidity with BMI of more than 40, or certain underlying conditions, particularly if not well controlled, such as diabetes, liver failure, lung failure, or renal failure, like patients on dialysis. I would include one more patient population here. There are immunocompromised, that are HIV patients also are high risk. And the people who are pregnant should be monitored since they are known to be at risk of severe viral illness. However, we don't have much of a data of COVID-19 that has shown increased risk in pregnant patients. Many other conditions in immunocompromised, the bone marrow transplantations, poorly controlled HIV/AIDS, as I alluded before, prolonged use of corticosteroids, the rheumatoid arthritis, all those people who are on immunosuppressants, biologics, they are at increased risk. Just going back to our principal thing, that how we do personal protective equipment, the figure on the left side, my left side, would tell you that the CDC recommends face shield and goggles N95, one pair of clean non-sterile gloves and a gown, and acceptable alternative PPE is a face mask, and all others are the same. This is a picture taken from a CDC. Then we go to some of the common symptoms of COVID-19. I'm sure everybody would be aware by now. It is the same as a regular influenza symptoms, including fever, cough, myalgia, shortness of breath, sore throat, runny nose, diarrhea and nausea, muscle ache, headache, pneumonia, ARDS, loss of sense of smell. Now I will elaborate a little bit more on loss of sense of smell. The people think if they lose sense of smell, they might get a severe COVID, or they might be having a CNS COVID. So I will elaborate a little bit about this. So also people might get renal failure, pericarditis, and disseminated intravascular coagulation. Here I would discuss a publication which was done from China, Wuhan city. There were 125 patients hospitalized, and amongst those people, the most common presentations were fever in 93% of patients, cough in 82% of patients, shortness of breath around 45% of patients, and the laboratory data showed lymphopenia in 48%, showed bilateral pneumonia in 80% of patients. I want to say something here, that the people who even have a normal chest X-ray, after they did a CT scan, 50% of them had a chest infiltrate, showing that they were not showing pneumonia on the chest X-ray, which was visible on chest CT. Also, patients showed multiple mottling and ground glass opacities in 20% of patients. All patients were given antiviral therapy, 15%, and patients were transferred to intensive care units. Now, this point, I don't understand that why everybody was transferred to intensive care unit, or only patients who had high suspicion or decreased oxygen, or they needed high ventilation, they were transferred to intensive care units. And they were followed from January 20th until February 18th, and none of these patients died, fortunately. And among the discharged patients, the median length of stay was 14.8 days. So in conclusion, this is a single center retrospective descriptive study. Fever is the most common symptom. Old age, chronic underlying disease, and smoking history may be a risk factor to worsen the condition. Certain laboratory inspection may contribute to judgment of the severity. So this was in 2020, April 11. The clinical management and treatment of confirmed COVID-19 cases. As we said before, apply standard precautions, contact and droplet precautions, and eye protection should always be used when caring the patient. If asymptomatic or mild symptomatic, can be cared for for in a single room with good ventilation and droplet precaution. Negative pressure rooms are not required. Usually the concept is the patient should be kept in the negative pressure rooms, which are certainly not required unless aerosol generating procedures. If you are doing intubation, or you're doing a tracheal aspirate or something like that. There is no specific treatment for COVID-19 is currently approved except chloroquine. The chloroquine has been approved as a treatment for COVID-19. Others we are giving them as per our experience. If you give supplemental oxygen to the people who have low oxygen, their morbidity and mortality seems to be better. If we give them IV fluids, if they are dehydrated, morbidity and mortality is better. Empiric antimicrobials, which we usually don't give. If there is super infection, yes, you can give empiric antibiotics. Then do not routinely give systemic corticosteroids for treatment of viral pneumonias or ARDS. I think probably my ICU colleague, Dr. Hussain, will agree or not agree. Probably we are giving corticosteroids to ARDS patients in pneumonias. Then I will discuss a little bit about the myths that I just prepared for just for the short time in between to see that how many people are awake. So it's a true or false question. Is COVID-19 a regular flu? True or false? I would probably take 5 seconds for people to give me answer. So 1, 2, 3, 4, 5, and then it is false actually, because COVID-19 is more infectious than regular flu, and it is more dangerous. However, while more infectious than other recent novel coronaviruses like SARS and MERS-CoV, it is less lethal than both. So this is a myth that was surrounding on social media. I thought maybe it's a good idea to go over this. Another myth is also a true or false. It is like, I am young and otherwise healthy. I have nothing to worry about. Is it true or false? 1, 2, 3, 4, 5. It's also false. So while it is more likely to cause serious illness and deaths in the elderly and those with chronic medical conditions, there have been plenty of severe cases and even deaths in the younger populations. Also, younger persons play a role in transmission, because younger people think that, mashallah, nothing will happen, and they go out and play football and tennis and cricket and whatnot. So I think they play a role in transmission of COVID-19. As far as the microbiology is concerned, SARS-CoV PCR samples, there should be deep respiratory samples, sputum or deep tracheal aspirate. Tracheal aspirate is more suitable if we can get it. Of lower respiratory tract infection, nasopharyngeal aspirate swab. Nasopharyngeal swab is the gold standard that we are doing right now, or oropharyngeal swab we are doing if upper nasal airway cannot be taken. Staff should be trained to collect the sample, and for intubated patient, tracheal aspirate is appropriate. We should send a SARS-CoV-2 PCR, and just think that even if a patient is coming with typical symptoms of COVID, but still we have to think in mind that atypical pneumonias can occur in these patients also. So we have to keep in mind that mycoplasma, chlamydia, legionella, we need to send respiratory viral panel that would include influenza, para-influenza, CMV, EBV, and others. Other investigations needs to be considered. If etiology is severe, pneumonia is not identified, we need to send Legionella urinary antigen, mycoplasma titers. Don't forget TB. because TB is a silent killer, and we have quite a lot of expat population, so we have to think about TB also. Opportunistic infection in immunocompromised patients like PCP, in patients like who are getting chemotherapies, or the HIV patients whose CD4 count is low, we have to think about PCP and the fungal infections. And all specimens should be regarded as potentially infectious, and healthcare workers who collect, transport clinical specimen should adhere rigorously to standard precautions to minimize the possibility of exposure to pathogens. Now, the recommended monitoring of parameters for drug therapy management. So what we need to do before starting the medications, we need to do routine profile, which would include CBC, renal profile, uric acid, hepatic profile, serum amylase, lipase, coagulation profile, G6PD for chloroquine, blood glucose, also for chloroquine, hydroxychloroquine, and frequent blood monitoring, blood glucose monitoring for patients with high risk of hypoglycemia. We need to adjust insulin if they are taking. Now, surprisingly, again, as I said, that the people who are normal in chest X-ray, 50% of them showed that they are having an infiltrate in the chest X-ray, and that infiltrate might have been from small to large. And then these people are in another category, that these people have to be treated as a moderate to severe category of COVID. And we consider CT scan of chest while waiting for COVID PCR as a diagnostic modality. Right now, we are doing in all people who are coming as COVID positive and as a mild symptom and getting admitted to the hospitals. When mobilizing the people to the CT scan and radiology, we need to ensure that infection control measures are followed during and after the transport. This is important. Otherwise, wherever you go or wherever you pass, you will be spreading the infection, which would be hazardous. ECG monitoring is a baseline ECG for each patient. And then every 24 to 48 hours, if there is suspected QT prolongation or there is a high risk of QT prolongation. Elderly patients, we need to do ECG. Patients with any electrolyte imbalance like hypokalemia, hypomagnesemia, hypophosphatemia, hypocalcemia, history of cardiac arrhythmias, or the patients who have concurrent QTc prolonging drugs like fluoroquinolones, macrolides, azoles, the others antiemetics, antidepressants, antipsychotics, antiarrhythmics, and avoid these and any other QT prolonging drugs in patients in COVID-19 treatment as much as possible. So I will show you a study in which they used hydroxychloroquine and macrolide, and it was not very successful study. Treatment options. There are various treatment options, including regimens provided. Suggested treatment is 5 to 7 days for mild cases, 7 to 10 days in moderate, and 10 to 14 days in severe pneumonia critically ill patients. All drug-induced side effects should be managed accordingly. Now, one important point, pregnancy should be ruled out if the patient is getting started on favipiravir, because favipiravir is absolutely contraindicated in pregnancy. Also, one important point, we need to get a consent form from the patient that we are starting COVID treatment, because it could be potentially toxic treatment. Laboratory and radiological monitoring baseline, as I said, we should be monitored. Then we have to repeat the PCR test after 5 days of initiation of therapy. Repeat blood test every 72 hours and imaging every week if clinically indicated while on treatment. Repeat more frequently in critically ill patients. Now, what is the treatment? The actual money Where is the money? The money is on hydroxychloroquine or chloroquine. And now this is confirmed COVID. You need to give 400 twice a day for 2 doses and then make it 200 twice a day, or chloroquine phosphate 500 twice a day for 5 days. This is COVID positive, not even a milder disease. The milder disease, we need to give it for 5 to 7 days, the same dose and the same frequency. This is acquired from American Journal of Critical Care Medicine, April 2020, was published in COVID with different severity, a multi-center study in clinical features. Then later on, the confirmed COVID-19 URTI without pneumonia. Now the without pneumonia is a catch here. We can give hydroxychloroquine the same dose and adding the favipiravir here. The favipiravir is 1600 BID for 1 day and then 600 BID for 2 days, or chloroquine, the same dose as I mentioned, plus favipiravir. Now the other treatment modality which we were using before we started hydroxychloroquine or favipiravir was leponavir ritonavir. It is commonly called as Kaletra in infectious disease language. It was a HIV medication. It is still HIV medication. It's called Kaletra. It is very heavy in the stomach. We used to give 10 years ago to our patients 2 tablets twice a day with hydroxychloroquine. Patient could not tolerate. Then we came down to chloroquine, hydroxychloroquine, and favipiravir. So leponavir ritonavir is obsolete until hydroxychloroquine or favipiravir is not tolerated. And then there was a study done about 30 patients. They used hydroxychloroquine and azithromycin. The problem is azithromycin can prolong QT, and then this study did not become very famous because of macrolide effect and QTC prolongation. So we are not using azithromycin as our first line treatment. The last slide was without pneumonia. Now this slide is with pneumonia. So what is the difference without and with pneumonia? We can use the same treatment, but a longer duration of time. That would be for 10 to 14 days. The last one was for 7 days or approximately 10 days. So hydroxychloroquine plus favipiravir or chloroquine phosphate, or we can use leponavir ritonavir plus hydroxychloroquine. There is investigational drug which is called remdesivir, which is not available. It's in phase 3 trial. It can be, we can get it upon a special request. Now, new treatment modalities that we have and we have tried in few patients is when the patient has early ARDS and there is a possible cytokine storm as per criteria set below that, and there is another medicine which is called tocilizumab. And now there is a whole criteria to use tocilizumab, and there is whole criteria to use interferon. There is a whole criteria to use interleukin 6, but I think it's above and beyond the discussion for today. So I will just take few names, and then probably might be in the next talk once they are little bit in, then we can talk about that. So if the patient is really sick and not getting benefit from hydroxychloroquine and favipiravir, we can start trying interleukin 6, which we tried in few patients, and fortunately it was successful. We can also try pegylated interferon. We can also try, as I said, tocilizumab, but you have to give at least 24-48 hours to wash out pegylated interferon or interleukin 6 from the system, human system body, so that it would not overlap. Now there is a debate about a convalescent sera, that if the patient who are getting better and you can get the sera from that patient, and you can give that sera to a patient who is really sick, that is still investigational. People have done few of these studies with plus minus reports, so we have to see some results. So now we come to important topics that probably people will appreciate, that they would like. What would be the consequences after the COVID-19 is finished and the person is healthy? So there are reports that COVID-19 can cause some renal dysfunction, as stated in this publication, which is from April 7, 2020, which states that COVID-19 and kidney failure in acute care setting in Seattle. So what they found, that acute kidney injury is more common amongst patients in more severe disease, particularly in the ICU setting, and considered negative prognostic factor. Organ dysfunction as a result of immune dysregulation and emerging of there is emerging evidence which suggests the possibility of direct cytopathic effect of SARS-CoV-2. And there is a report of albuminuria and hematuria in the setting of COVID-19, along with isolation of viral RNA in the URNA in the urine. Further supports the potential viral tropism of the kidney. So I think all viruses have tropism to the kidney, whether it be EBV or other viruses, the rejection viruses. The kidney has more tropism for the viruses. Myocardial injury, the frequency of myocardial injury is reflected in elevation of troponin I among hospitalized patients that were reported from Wuhan from 7 to 28%. Some studies even identified greater frequency of magnitude of troponin elevation. Data are lacking for the frequency of troponin elevations in asymptomatic or only mildly symptomatic patients in SARS-CoV-2 patients. In a series which was done in Wuhan, China, 416 COVID patients who were hospitalized, 19.7 had high sensitivity troponin I positive. Patients with this marker of myocardial injury were older and had more comorbidities like chronic heart failure in 14.6 versus 1.5% in young patients, greater laboratory abnormalities, higher C-reactive protein, procalcitonin, aspartate aminotransferases, more lung radiological abnormalities, and more complicated compared to those without myocardial injury. The mortality rate was also higher in those with myocardial injury. So 51.2 versus 4.5%. So we can say that the myocardial injury was more in the people who were elderly and they have more severe disease. The risk of death starting from the time of symptom onset was more than 4 times in higher patients with evidence of myocardial injury. So supposedly these patients were elderly with more comorbidities and they had more deaths in this cohort. Then heart failure. This is also a retrospective trial which was done in Wuhan again with almost 800 patients, and 49% of heart failure was identified in the patients who were discharged or the patients who were severely sick, and 3% of who were recovered. So 49% in patients who were severely ill. And in a study of 191 patients hospitalized with 2 medical centers in Wuhan, heart failure was identified in 52% of patients who died in 12% of patients who recovered. So heart failure is a major issue, and it's not that major issue, but the people who have more comorbidities, for them it's a major issue. So people who are elderly and they have more comorbidities and they have a heart problem, they are more prone to get it. CNS, there are anecdotal reports that COVID-19 causes CNS effects. It can cause involuntary movements, bothering controlling the inspiratory area of the brain stem. It can also cause neurological deficits, can cause encephalopathy. Some people had encephalopathy, which might be reversible. I have a photograph of suspected COVID-19 encephalopathy, which was later on reversed, and the patients became fine, but you have mild cognitive dysfunction, which improved over the time period. Now, investigational approaches that we have vaccines. There are numerous candidates are being evaluated for vaccines. The first vaccine to undergo preliminary study in human, it will be in RNA platform. It is under process, and there is an interesting thing that the BCG vaccination, which was requested before, which we usually get in developing countries, and clinical trials are underway to evaluate its use among healthcare workers. Studies, there are many studies have been suggested that although it's a primary purpose for prevention of tuberculosis, but BCG immunization includes a non-specific immune system that may have protective effects against non-mycobacterial, including viral illnesses. So it would be news in maybe few weeks, and there is a whole lot of debate on post-exposure prophylaxis that we usually do in HIV, but still it is controversial that whether post-exposure prophylaxis would be important or not. Now, there is also a concern that if a healthcare worker takes a prophylaxis like 200 or 400 hydroxychloroquine twice a week, once a week, he will be protected. The answer is no, because we don't have any randomized controlled trials that would say that it would be protected. In future, we might know more about this. So in summary, I would say COVID-19 is widely distributed, very contagious viral infection. Common symptoms are similar as URTI, fever, and fatigue. Positive patient needs to be admitted and quarantined. Nasal swab or tracheal aspirate for PCR diagnosis. Hydroxychloroquine and chloroquine and favipiravir is the mainstay of treatment that we are giving to the patients, and they are getting better. And treatment depends on severity of illness. Infection control methods should be applied. Renal, heart, respiratory, CNS can get infected after there are severe infections. New treatment modalities are coming, and close monitoring is needed. So that's my presentation. Thank you all, and I would be happy to take any questions.
Hi, this is Dr. Omar from Zayed Military. I have a question. First of all, good presentation. Thank you for that. Now, obviously, you mentioned here that all positive patients need to be admitted, but surely we are coming off that now because we can't admit all patients. We are going to run out of capacity if we start admitting all patients. So we have to have somewhere to quarantine them in the community. I mean, in the US, they're doing it at home. In the UK, they're doing it at home as well.
Hello?
Yes, hi. Yeah.
Yeah.
But can you hear me?
Not really.
Can you hear me now?
Yeah, it's fine. Go ahead.
Yeah, so basically, as you mentioned, that you're saying all positive patients need to be admitted and quarantined. So quarantined is fine, but I'm assuming you can't admit all positive patients anyway, because at one point we run out of capacity to admit all patients. I mean, they've moved away from this in the UK and the US, so presumably we've got something set up where we are going to have community quarantine.
Yeah, I agree. We are having multiple meetings during the week, and we are moving to that route. Actually, Dubai has already started home quarantine, and we are going on that route. Actually, we are not getting admitted all these patients to the hospital. The people who are moderate to severely sick, they are getting admitted. The patient who are positive and mild symptoms, they are going to one of our hotels. That on those hotels they are quarantined, so that we would know that these people are not meeting their friends and families, so they would be quarantined over there. There are a couple of doctors over there, so there will be no human socialization over there. You're right, we are going in that route. Maybe in coming week or two we would be going on there.
So so when do they get? Sorry, when do they get de-quarantined from there? Is there a criteria from DOH or MOH? You know, how long are they going to be quarantined in the community?
Sure. There is a criteria. If you have a contact with a positive COVID patient, then you will be quarantined for 14 days. Then you will come out. There's a primary contact. Now the people are saying that even with the primary contact, if the risk is moderate, then you can still come and work. Number two, the patient who have COVID positive, they would be given medications, and they will be checked for PCR. If 2 consecutive PCR are negative, they would be taken out of quarantine and sent home. Number 3 situation is if the 1 PCR is positive and the subsequent PCR is negative, then you need 2 negative PCR to take him out from quarantine and discharge the patient.
Thank you.
Yeah, we in the Northern Emirates are following a similar path, just to confirm. Very similar. They mild cases, even if they're admitted, sometimes they're admitted for a day or two, and after 1 or 2 days, if they're very stable, then they can be transferred to the hotel, as long as they're not needing any medication.
Sorry, this is just a consensus question. Are you all patients hydroxychloroquine if you're putting them in the community?
The people who are on hydroxychloroquine.
Yeah, do they go to the community as well, or are you starting?
We're not. Our patients who are going to the community, I don't believe are given any medication.
Yeah, I think the question is the people who are sick, mild to moderate, or they have positive. People who are taking hydroxychloroquine, they are not in community. They are either in the hospital or in the hotels. So these people are quarantined. Once we make a policy that these people, if mild disease or asymptomatic disease, then they would be given for only 5 days of hydroxychloroquine, and then they can go out in the community. But I don't know why this question came into your mind. Anything related to hydroxychloroquine?
I mean, in general, if you are using, sorry, go on, Naeem.
No, I think our hotels or quarantine, they don't want patients on any medication. So they're only going there once they're needing no medication. As long as they're on medication, then we tend to keep them in as inpatients at the moment.
Yeah,
I agree with that.
For us in Emirates of Abu Dhabi, we are admitting mild to moderate since our flow is more. Mild to moderate disease in the hospital, asymptomatic and a little bit on the milder side disease, they are in the hospital and they are getting medications in the hotel and they are quarantined over there.
I mean, I would be a bit wary about giving medication in the community if, who monitors their QTC and all the sort of things. Is there doctors in the hotels?
Doctor, it's not in the community, it's in the hotel. There are doctors and we are reviewing their charts. There is doctor over there, there is nurse over there checking their pulse, their temperature. And in the hotel, I have a list of 100 people. I review 50 of them every day. So I'm reviewing them.
Thank you.
And then I am also requesting them, whoever gets a dizziness or something for ECG, their labs, 2 to 3 days. So these things we are doing it actually.
Thank you.
Thank you.
Assalamu alaikum, Dr. Aqil. This is Dr. Hussein. Can you hear me?
Yeah, Dr. Hussain, welcome.
Thank you very much. I enjoyed your presentation entirely. I always learn from you. So I have a two simple question. The national guideline that you showed actually, and I think everybody also anyway has received it, and they received the new one. At the end, it has a consent form. So my question is, do you use the consent form when you give your patient treatment? And the other question, is it mandatory? Because the guideline is most likely, I think, coming from Abu Dhabi, from Saha. Now I'm not in Saha anymore. So is this consent mandatory when you
Dr.
treat your
Hussain,
patient?
you have to come back to Saha to get this answer.
So you don't have the answer?
No, I know the answer. I will give you the answer. Initially, we decided to get a written consent, but now what we are doing, we are taking a verbal consent. Verbal, we are telling them that we are giving you medications for your good to treat COVID-19, and they 100% of them agree verbally that it's fine. We write it down that verbal consent has been taken. So that's what we are doing.
So then if it's a verbal consent, it's something that we do for anything. Even if you give any antibiotic, you explain. So why then that consent was put in the national guideline? Because we get the message, it looks like a mandatory, which should be, in my opinion, because this is all investigational drug. We don't know. And as you mentioned, some has acute and terrible side effect, nausea, and all of the above. So my humble opinion, since things are changing, you know, the studies come, some studies says this drug is good, and after 1 week this drug is not good. You know this. So my humble opinion that it should be mandatory. So if you then it is all the doctors feel safe that what we are doing is right, and we're at least patients are aware of the consent, unless they are unconscious or uneducated. That's another discussion. That's my only question I have.
Yeah, actually, you know, there is a lot of debate on the consent, whether we do it verbally, written. So I think in coming maybe 1 or 2 weeks, it will be decided by health authority, by our hospital, and by SEHA that what would be the next step. But currently, what we are doing is taking a verbal consent.
Shukran. Thank you very much. Jazakallah khair.
No problem.
Dr. Aqil, thank you very much for this amazing discussion on treatment modalities. I think it was more of a breakdown of almost everything that you could need as a review for the end of our day. So it kind of settles in nicely to what we've discussed so far. I have a few questions from the meeting chat, starting with the fact that what are your opinions about the fact that a gold standard, the nasopharyngeal swab is considered a gold standard, but a CT is still only for clinical manifestations of disease. Do you believe CT could probably supersede nasopharyngeal swabs in screening, or do you feel like nasopharyngeal swabs?
No, I did not mean that. You know, I think there's a little bit misunderstanding. Nasopharyngeal swab is the #1 thing to diagnose COVID-19. And once the diagnosis is established, then you have to go for chest X-ray. And if chest X-ray is negative, then you have to see the CT chest, because 50% of the infiltrates are missed on chest X-ray on COVID-19 patients. So it is first is establishing the diagnosis, and then going to the chest X-ray or CT chest.
That makes sense. I think I misread the question as well. We have another question about whether or not the saliva test can be used to probably substitute or replace.
A saliva test, usually I think it's not valid for most of the tests, most of the viral or AFB or any test that we are doing. I think it's, I have done myself a COVID test, and it's pretty painful, you know. They put a swab and stick it in your nose until they reach your sinuses. So they potentially open your sinus. So saliva is not an option. You have to do this swab or tracheal aspirate or nasopharyngeal aspirate.
Thank you very much. There's two other questions about the reinfection rate. As far as I know, it's anecdotal, or there were a few cases of this, but what is your opinion about the chances of getting infection after recovering from COVID-19? And someone is asking about if there's data on this.
Yeah, actually, the co-infection would be little less because we have developed the herd immunity, the person who already took it, who already had this COVID-19. It could be possible, as you said, that we have anecdotal reports that there are 8 or 9 mutants of corona now. So you might end up getting the next mutant, but it would be less. I think it would be less disastrous than we have it now.
All right. Does anyone have any more questions? I see some questions coming in about the use of anticoagulation for severe cases and thromboembolic phenomenon. Dr. Akil,
Yeah, I read this interview of recent talk about thromboembolic phenomena caused by COVID-19. I think these are all anecdotal reports: thromboembolic phenomena, disseminated intravascular coagulation, sepsis, all these. So I think we have to take case by case. If the patient has, these things, then we have to monitor them as a case by case rather than generalizing the fact. So maybe, I might have seen one, other person might have seen the other. I might have seen the CNS encephalopathy, the other might have seen the this thromboembolic phenomena. So I think it's one by one. I think none of the people will know everything, each and everything of COVID, because it's still evolving field. So I would just keep our studies tight, our hands tight, and see what's going to come next.
I agree with that statement. Most of everything we've discussed today could change tomorrow, just like you said, and Dr. Hussain also mentioned. I mean, this is what we know so far. And the purpose of the activity today was just to have a tangible amount of discussion that we can say this is what we know so far and what our best guess based on your expert opinions.
I think there is another question about the serum. As I mentioned briefly, in the plasma of the people who got infected and recovered. Can it be used? It can be used as a passive immunity, but the problem is we don't have much of a data on that. Once we have a data, I think US is trying to give their passive immunity from the plasma of the patients who got better, and then we will see that how it's going to work, and then we will start doing it. But currently there is no data for plasma that the people who got better with IgGs and all the immune system that they have in their system.
We have some more questions as well.
I think Dr. Hasna is asking, thank you to organize the talk. My question is, our lab does specific type of COVID. Can we affect our treatment to be more aggressive or not? Our hospital do COVID-19 specifically, and the treatment is fixed treatment. We have hydroxychloroquine and favipiravir. That's the fixed treatment, and if we get any other treatment available, maybe tomorrow, day after, week from now, we would be going to that treatment. So that would be the answer of that question.
In fact, actually, there are a couple of trials underway. So by the end of this month, there's going to be 2 or 3 more publications. And like you said, tomorrow, day after, there's going to be more and more changes. So we have to see each patient as we can give our best clinical result as well. Are you giving treatment to all COVID? I think this is the big question by Dr. Naeem.
Actually, as I said, the patients who are not symptomatic, we are just giving hydroxychloroquine for 5 days. The mild and mild people will get hydroxychloroquine for 7 days. Then mild to moderate, we will give 7 to 10 days along with favipiravir. So currently, yes, we are giving to all patients who are even positive. But I would think it would come off that the people who don't have any symptoms, they probably will not get any treatment. It would come. I'm pretty positive, in maybe few weeks it would come that it's not going in that route. Another thing which I want to tell you, the new treatment modality was leukotriene 6. Leukotriene 6, which was tried in Tawam Hospital in a couple of patients, and it was successful. So that's the way to coming in, and they were pretty sick patients, and they got better. They turned around. So as you said, we will probably going. It's kind of a evolving field. So maybe a couple of weeks we have something else. In few weeks we are going to see something other things. So maybe in a couple of weeks we'll have another talk and we'll see what is new.
Inshallah. I guess we'll wrap it up with one last question by Ahmad Nijm. Any opinion about antibodies, IgM, IgGs, if it's available, and are we using this?
Yeah, actually, as I alluded before, that we have passive immunization in the people who had COVID before, and after they recovered, their plasma might have antibodies, IgG, available, that might be given as a passive immunization to the person. But until now, we did not hear a lot of reports about that, but it's one of the possibilities. I think in US and UK and Western countries are doing that, and there is some success with that. So I would say yes, this might be coming in few weeks.
I think that's fair. Before we proceed with any further discussions, since it's the end of our day today, I just wanted to thank everyone before they leave for congregating and being here for these discussions. Thank you to all the doctors and speakers who came and made the time out to present their lectures. It was truly an informative day. I just wanted to mention that while we are discussing and getting ourselves up to date with this disease, unfortunately, there are a lot of people on the other side of the spectrum. We have doctors and families and friends and relatives on the patient side of this disease, and I just wanted to offer a moment of prayers from all of you people. We have a colleague, Dr. Nadine Qureshi, who was, alhamdulillah, just extubated today after going through ECMO in a pretty devastating series of events. He is on his way to becoming better, but more than a few people have actually been lost to this disease. And I would like to offer a moment of silence, if that's okay with all of you, just to pray for those fighting and who have fought with this disease.